advocacy. And what stood out for me was Professor Patrick spoke about how research can inform policy. So as much as we're doing publications and doing all the work, how can this information be directly included in the policies that are being made in the country? And the other important thing that came up around that discussion was the task sharing aspect. So as much as we're training primary healthcare workers on the image gap, how then can they be more empowered to continue to provide care at the grassroots? And then we had the second panel discussion that was led by Mrs. Sabina, incoming Dr. Sabina. Very interesting and moving experience around people with lived experience. Some of this, passionate, experiences that were shared that I think really moved the room and just reminded us why we're here. It's mostly for the people with lived experience and their caregivers. Next slide, please. Good. So the final, tying it all up, we then had our workshops, which were very interactive. So we had two groups, one group looking at advocacy and one group looking at policy. And again, the main points that came from the workshops is a lot of progress has been made in Ghana since the 2022 meeting. We've had the MH gap training, we've had a lot of awareness creation, but there's still room to do more. Levetiracetam is still not in the essential medicines list for Ghana, so this is something we still need to push for. The National Health Insurance Scheme is working, but then there's no linkage between specific diagnostic and specific medications. So for instance, if you want to prescribe carbamazepine, it's not listed for epilepsy. It's listed for like mood disorders. So you'd probably prescribe for a mood disorder so that your patient gets carbamazepine. So there are still gaps around just making sure that the insurance scheme works and it speaks to the current practice. How success would look like if we're able to implement some of these. We'd have a national strategy for epilepsy and neurological disorders. So this would be like a standalone policy document that speaks to neurological disorders within the broader non-communicable disease policies. And we also have improved access to care and to medicines due to the reduced discrimination as we reduce stigma. And so overall, day one showed us that there's lots of growing research capacity. There's lots of commitment from the Ministry of Health, from the national leaders, from the Ghana Health Service. There's clear frameworks within the region, so we can easily just bring this together to actually move forward the discussion around IGAP implementation. Thank you very much.
I'm not too sure whether we didn't sleep well today or we are just tired. Can we all be upstanding a little bit, please, so we have a little bit of a stretch, and then we continue from there. And this stretch, we are all going to spell love. We are going to spell love. Maybe let me be here in the middle, so I show how to spell love. Okay. Thank you. Oh, you see, when we stand up, we are a lot, actually. So first, we spell L this way. Good. That's nice. And O that way. Perfect. B that way. I kind of don't know the E, but we will do this way. Thank you very much. Thank you. Thank you. All right. So thank you to our latest doctor. Is it possible we could all come forward, please? Those at the back, we please plead with you to come forward. Thank you. Please come forward. Thank you to Dr. Mercy Atieno. Did I add that she's just the latest PhD graduate 2 weeks ago? So we are grateful. Thank you. Thank you very much. It's a big success, and the project has actually is grateful on that. Next is the session that we are going to have on access to medicines. Access to treatment. And this session is going to be chaired by Professor Arjun Sen, and he's going to moderate the session as to how it's going to go. We have the members of the panel who are going to comprise this session from the Ministry of Health, the National Health Insurance Authority, the WHO, and a service provider. So with, please, a round of applause, let's welcome Professor Arjun Sen, the chair for this session.
Thanks very much, Daniel. And yes, congratulations, Mercy, on the PhD. It's a constant source of embarrassment that we will always highlight this, but many congratulations. So Patrick told me yesterday that Fridays are Africa Wear Day. So I put on a shirt, but Patrick is wearing exactly what he wore yesterday. So, so we're going to just do a little bit of framing about medicines access in low to middle income countries. Then we'll ask the panel to come up. We're going to have this as quite an interactive panel discussion. So whilst we'll ask the panel certain questions, we will also put things to the audience so that you can share your views during the panel. And then at the end of the panel, we really want to wrap that up around some action points. So some clear, agreed action points that we can try and take forwards. Okay, so medicines access in low and middle income countries, what it is and what can be done. So next slide, please. Sorry, can we just move to the next slide, please? Oh, thanks. That's not quite working though. Okay, great. Thanks, Danny. So neurological disorders, the reason treatment of these conditions is very important is that they are common, as we said on the slide yesterday. They associate it with the highest disability adjusted life years, the highest years of life lost. There's a very high treatment gap. And actually, though, if you treat neurological disorders and you treat them well, you can have very clear impacts both on direct benefits and indirect benefits. And we talked about that a little bit yesterday, remembering that the indirect cost of epilepsy can be much greater than the direct cost of epilepsy. And epilepsy is very much a treatable condition. So there are a large number of anti-seizure medications, and this continues to increase. Fenfluramine has come out after this slide was put together. So there are lots and lots of medications that can be used. And access to medicines is actually enshrined in law. It's a legal right to be able to access medicines. So, an access to medicines is defined as the reasonable ability for people to get the needed medicines required to achieve health. Health being defined in its broadest terms. So, health is not just an absence of disease, but it is actually being healthy. And such access has been deemed to be part of the right to health, supported by international law since 1946. So that's 80 years ago that it became a legal right to have equitable access to medicines, but it still has not really played out on the ground. So in order to get interaction going, I'm going to ask this question. And so you can only really vote once, okay? So I want you to say whether you think the main barrier to good medicines access in low and middle income countries is not enough people seeking medication, not enough prescribers, not enough medicines, not enough money, not enough engagement, okay? So we'll just do it with votes with a show of hands. So who thinks that the main barrier is not enough people seeking medicines? Nobody? Okay. One. Okay. All right. So thank you. Not enough prescribers, not enough people to prescribe the medication. Yeah. So one. Okay. One, two. I said you could only vote once. So you voted twice on the two questions, right? So, but, and you might find they're all true. But anyway, not enough medicines. Okay. So then not enough medicines. Okay, so a few hands for that. What about not enough money? Yeah, I'm sure you voted twice, Albert, as well. Um, the but okay, so many more people for not enough medicine and not enough money. What about not enough engagement? Yeah, Who's going to say, actually, it was unfair for you to ask to vote for one? It's all of those. Everyone? Okay, well let's see how it goes through because it is all of those, but actually it's where you put the emphasis. And you could argue that if there wasn't enough engagement, it wouldn't matter whether you had enough money, enough medicines, enough prescribers, and enough people seeking medicines, because if there wasn't true engagement, nothing would work. Yeah. So one of the things is that actually just putting money into a problem, in inverted commas, doesn't necessarily lead to a solution. It's not just about money. It is much broader than that. And that's what we're going to explore in the panel today. So this was the fishbone analysis that the WHO did to look at barriers in health systems affecting medicines access, again in neurological disorders. And you can see they had many more things. We talked a lot yesterday about stigma and awareness, and that also speaks to engagement. If a condition is highly stigmatized, that can prevent engagement, that can prevent access, no matter whether the medicines are available and there are enough prescribers to give the medication. We also need to get to this point, which is policy prioritization, because unless you can actually change policy, then there's not enough sustainable drive to actually enshrine that going forwards. So the 7 A's of medicines access, as I have sort of put them together, are awareness, appropriateness, availability, accessibility, affordability, I think is next. Affordability, applicability, and sustainability, because I couldn't get that to work with an A. So these again are the things that I'm just showing this. So this is how we're going to frame the discussion going forward. So the awareness, appropriateness, availability, accessibility, affordability, applicability, so the right medication for the right person, and sustainability. And what I really want us to think is that we can definitely do something. So it's not saying that we can all walk on water like these children are doing, but we can do something. And with that, I'd like to just call the panelists up, if that's okay. So I'm not sure exactly who the panelists are. So, but if you are on this panel, can I ask you to come forwards for me? Yeah, Emmanuel?
Right. Okay, so to help with the discussion on the access to care and medicine for epilepsy and other neurological conditions, we have for the panel from the Ghana Health Service, Dr. Ajuaku Sitre. Please, let's give a round of applause as she comes. We have Dr. Eunice Sabam from the NHIS, Health Insurance. She's coming, okay. We have Dr. Selena Dusey from the WHO. From Ministry of Health, sorry. Dr. Selena Dusey. For you?
That's okay. But
Okay, sure, okay.
Okay. Panel of one so far. So should we, is there anyone else?
Yes, and then from the WHO, Dr. Debbie Najima. Please, let's give a round of applause. So we have Dr. Eunice Abam. Selena. Okay. Minister of Health, Dr. Selena Dusey joining us. You're welcome. Start. So I think we can.
Okay.
Yes.
So put this down the middle. Great. Great. Thank you very much. Thank you very much as well, panelists, for joining us. So I wondered if we could start by just a very brief introduction of yourself and your role, and perhaps why you think medicines access is so important in Ghana, if that's okay. If I could ask you to start, please.
Hello?
Yeah.
Yes. Please, good morning. My name is Eunice Nkroaban, the Deputy Director for Strategic Health Purchasing Directorate with the National Health Insurance Authority. Our apology, we couldn't make it here because we had a management meeting as well as we had a meeting with the Ministry of Health. They had called us in, so our apologies, management to the institution. Yeah. So for epilepsy is one of the conditions we at NHI prioritize so much. And so on our medicines list and also on our treatment pathway, we have things we cover under epilepsy because it's one of the neuro conditions. I mean, you wake up one day and you have it. Sometimes I have a cousin who has epilepsy, and it comes as and when. And when it comes, sometimes in school, people would discriminate against him and all that. So I've had epilepsy at a point in time in our lives where you go to school and he has an episode and you are rushed to, they rush in to come and call you. This your cousin is having an episode, all those conditions. And so having myself as an NHI and seeing the dozen of lists and conditions in our benefits package that we cover is a good thing for us. But unfortunately, with our healthcare practitioners, I always say this, that let's always allow NHIA to cover what we cover. People go to the facilities with conditions, and in as much as NHIA, we are told NHIA doesn't cover this, NHIA doesn't cover that. Benefits package, also medications. But the good news is that we have revised our tariffs. I think that one of the major conditions that, or the major situations that's always allowing our practitioners to treat such conditions, not even in epilepsy alone, but across all the different conditions, is that our tariffs are low. But God being so good, we've increased our tariffs, which will be rolled out very soon. And so please, let's allow the NHIA to cover what we have under every condition, inclusive of epilepsy. Thank you very much.
Thank you so much. Thank you.
So good morning once again. Today I'm a panelist. My name is Dr. Levina Jima. I'm a psychiatrist primarily and the technical officer for mental health at the WHO country office. So my portfolio covers mental, neurological, and substance use conditions. And I was privileged to have been part of the IGAP meeting in 2022. And so I have some institutional memory of what we are discussing. And I believe from that meeting, throughout my practice, access to medicines has been one of the major challenges that's been echoed throughout discussions, either by professionals or by caregivers or persons living with neurological conditions. And I believe that it's important we have a lasting solution to it as a country to support our people.
Thank you so much.
Good morning. My name is Ajwa Kusitre. I'm also a psychiatrist and I work with the Ghana Health Service Institutional Care Division, Mental Health Department. I was also very privileged to be part of the EPINA project. I was actually a facilitator and supervisor for the project. and part of the MH gap intervention in the country, which also includes task shifting and sharing and building capacity in the management of neurological conditions such as epilepsy. And because of where I sit, and with the work that I do when it comes to supervision, I have some knowledge about the challenges that patients face when it comes to accessing medications. But I am also aware of the progress that has been made, and I'm very happy to share insights on this as well. Thank you.
Okay. Thank you all so much for the introductions, and thank you for chairing yesterday. So we'll try and do a similarly good job if we can. So in terms of setting the scene, if we try and set the scene at the moment, because we already came a little bit to one sort of possible solution and of aligning the tariffs, but if you set the scene at the moment, from your point of view, how would you say medicines access is in Ghana at the moment? Focusing mainly on epilepsy, but epilepsy intersects very closely with mental health disorders, and we know that if actually just treating seizures isn't enough, you need to treat all of the comorbid conditions. But how would you say sort of the current situation is in terms of accessibility and availability? If I could start with you, perhaps, if that's okay.
So at present, as was earlier mentioned, epilepsy is covered under the National Health Insurance Scheme benefit package. The challenge mainly is to do with, from my experience, is the level of access in terms of facility and in terms of the provider or the clinician. So per the structure of the NHIE, there are levels of care for which certain medications will be available to the service user. So even if the medicines are available and you are not accredited to that level to provide or to prescribe that medication, you will not have access. Mm-hmm. And then even if a provider like a specialist goes to a lower level and prescribes where they are, because the facility is not accredited to that level of specialty, it will not be accessible. But otherwise, across from the lower level to the highest, there are certain medications that would be available for service users, depending on who is prescribing and where they're being seen. But generally, the common medications, carbamazepines and the others, are readily available from the lower level upwards.
And so can I just ask a little bit more really for my education on that then? So who determines who can prescribe which medication and who determines which facility can prescribe which medication? Okay, please. Sorry? Okay.
Thank you very much. So the NHI determines who prescribes as well as the level of prescription. Just as with other conditions, there are some facilities, healthcare facilities, some with doctors, some without doctors. And so we advise that to take someone with a condition like that, you have to know the type of facility. If you go to the CHIPS, you won't get access to some of these conditions. I mean, a facility like the CHIPS where you get a doctor to prescribe and even give you treatment. Mm-hmm. For medicine access, just as I said, we cover about 5 of them, of which you also you mentioned. And we have consultations and diagnosis as well. So for the access is there, but the level of prescription and the facility to prescribe lies with the National Health Insurance Authority.
Okay, and so just because these complexities around medicines access apply everywhere, they apply in the UK as well. And so one of the things in the UK is that now in order to start an anti-seizure medication, many of the anti-seizure medications you need to see a neurologist. But then once the medication gets up to a stable dose, then primary care could continue prescribing that medication. Is that the same here, or would it always, let's say it's levetiracetam, for example, if you need to be at a specialist level to start the medication, do you always need to go to the specialist level to get to the medication, or can it devolve down a little bit once the dose is stable?
So level of prescription is the same level of medication or treatment as well. So there's no difference where you can get to the level of treatment here and take the medication on another level. No, it
It would
works
stay the
like
same.
that, yes.
It would stay the same. Okay, thank you very much. Okay, so and anything you would like to add in terms of the current state of the availability of medications?
Yes. I wanted to add that currently in our country, we don't have many neurologists, and yet the burden is huge when it comes to epilepsy, particularly in rural and remote areas.
Mhm.
So over the years, we have been using tax shifting and sharing approaches to build the capacity of primary healthcare providers, medical officers, and prescribers to be able to diagnose and manage epilepsy.
Mhm.
The common type of epilepsy, which is the generalized tonic-clonic convulsive seizures. And I must say that currently and practically in our country, these prescribers are also supported by the mental health units, particularly at the lower primary health care levels. So you may have primary health care providers diagnosing patients and initiating treatment once epilepsy is diagnosed. And that person may not have seen a physician specialist or a neurologist and continue treatment within the primary health care level.
I mean, and at a practical level, at a pragmatic level, that's very necessary, isn't it? It's going to take time to upskill lots more neurologists or other specialists. So if you can use that task shifting approach and try and get people in local communities where there may be more trust anyway, because it's a local community, would save a lot of money in terms of travel costs and other expenses, might save a lot of time, so that would save the indirect costs. So if you can upskill local people to at least start the initial medications, and then if things become more complex, then it would escalate up to the other facilities. That would seem very, very reasonable, as long as those facilities in rural communities can prescribe the medications, have the infrastructure to prescribe the medications. Okay. And then, so this is a slightly loaded question that is here, which is, but I'll read it as it's put. So how effective are existing national policies, guidelines, and essential medicines lists to actually helping people with epilepsy? What would you say? Bearing in mind this is all being recorded.
Yes.
So
Okay, so prescribing levels, just as I said, at the tertiary, secondary, primary levels.
Mhm.
But we still have gaps which we are so much aware of that
What would you say the main gap is from your organizational perspective? What would you say the main gap
so we
is?
think that we can expand the medicines list or the benefits package to include the very newest medications or conditions that surround epilepsy or neural conditions. So we are thinking of pharmacoeconomic assessments to help provide alternatives for patients that are unresponsive. We are also looking at data and cost-effective reviews, getting or sitting with a health technology assessment or a periodic review of some of these conditions, because sometimes you receive data from the field and data will give you just a minimal overview of whatever that is going on. So data should be in real time to reflect whatever that is actually going on the field. And so we are looking at getting a health technology assessment unit sitting with the National Health Insurance Authority. There's one with the Ministry of Health, but one sitting with the National Health Insurance Authority that would get data in real time on some of these conditions. And so we appreciate the fact that a lot is being done when it comes to the benefits package and the medicines list, in as much as we even take some of these medicines from the essential medicines list. Our medicines list is extracted from the essential medicines list from the ministry, yes. And so we work hand in hand with them when it comes to that. But we are also not, we are so much aware of some of these gaps and we are talking it through. So from here, all concerns that come up when it comes to these things would be well written, documented, and sent to management for some of these inclusions. Day in, day out, we revise our medicines list. As I speak to you currently, the National Health Insurance Authority is on the field gathering data to update our medicines list. We review it every year, as well as our tariffs. So it's a practice that we do. But in as much as we do that, we also appreciate some of the concerns that come in. We get people come in with additions to medicines and conditions from other institutions, like the University of Ghana can write to us and say, oh, we've done a research in this, we think, or we recommend that this is added to your medicines list, this is taken out, or for the benefits package, you add this to the benefits package to assist. And so all these things are being done to help improve the access to medicine and our benefits package as well.
That's terrific. You said a beautiful word there, pharmacoeconomics, which is something that we should certainly note down, because if we were, as we were talking yesterday about, if you have to demonstrate cost efficiency and cost effectiveness as well, if you're going to really implement policy. And so just a little bit more, so the Ghana National Medicines List, as compared to the WHO Essential Medicines List, does it update very quickly? Do those update quickly, or does it take time to get from the WHO EML to the National Medicines List?
Okay, so what I can say from our end is that the Ministry of Health works directly with us, but the updates which as I think throughout the year, they look out for the new trends and the updates with WHO to update the essential medicines list, which we all take, medicines from to work with. And so they update day in, day out when there are new additions or subtractions and all that. They do that periodically. Yes.
Perfect. Thank you so much. So again, the same questions as we go down the line. So how effective would you say that the current guidelines, essential medicine lists, policies are in terms of ensuring true medicines access on the ground?
So thank you very much. I'm aware that from the last IGAP meeting we had, when we deliberated on the challenges with access to essential medicines, following that meeting, there have been steps by the government to update the medicines list and also the national treatment guideline, which is ongoing. Some sections have been updated, but the challenge is that there's limited funding to complete the entire sections and put it together as is usually done to make it available for the service to utilize. And I think one of the major challenges that's been addressed is the upgrade of the tariffs, as been mentioned, which deterred providers providing the medicines on the benefit package because of complaints of not being able to make profits, or at least be able to get the market value of what they were getting based on what the insurance was providing. So that is a major barrier addressed. And then the review of the policies, as well as creating a lot more awareness of the insurance policy and benefits that are available to provide it, or their clientele base. Over the years, there's a lot of awareness on social media on the space on what insurance does, how you can acquire a valid card, and where you can utilize that. I think one of the bottlenecks when it comes to neurological conditions has to do with people being aware of the condition and the fact that there's help available to access care within the health services. And so that is one major bottleneck. And then also the prescribing levels. That makes it difficult for people who require medicines above what is the basic minimum. That is, if there are reactions to certain medication that would require other effective but less has less side effect to be available at the levels that the individual may be accessing care. So those are some of the policy challenges and opportunities there.
Yeah. No, thank you. That's so very important things there, because if we go back a little bit in terms of the infrastructure, and if we were saying that there might be certain medications available in the rural community, but that for other medications you would need to go to a higher level. Say, for example, you try carbamazepine and you get a rash with carbamazepine, that effectively rules you out from trying phenobarbital and phenytoin because you're very likely to get a rash with one of those drugs as well. So actually trying to ensure that there's good access through the pathway is going to be critical. And again, as you said, highlighting bottlenecks is the key thing. So, and if I can ask you as well, so from your perspective, from the organizational perspective, what would you say that the current state of the guidelines are, the current state of the essential medicines list, and perhaps a little bit as to where the bottlenecks might be and where the gaps are?
Okay, thank you. So what I want to contribute is the fact that I think the policy guidelines and SOPs are there, and they are being reviewed day in and day out. But I find that a lot of the time, those in the supply chain system, those involved with the medication supply chain system, often do not have their capacity built fully to even appreciate what's in the SOPs, the reviewed guidelines and SOPs. Because looking at the policies, provision are made available even for situations where facilities stock out and are not receiving medication nationally, to be able to procure at the hospital level to make up for the stock outs. Mm-hmm. And then also there are challenges with requisition in the GILMIS, which informs the forecasting and supply planning. There are challenges. You have some places where there isn't enough engagement and collaboration between those who matter, the focal persons who inform the requisition based on consumption needs. So sometimes you may have cycles going and no requisitions are made for the medications. So what happens is that you may have some facilities and some regions doing well. When we go on supervision, we find that they are not even aware of the current SOPs and guidelines and what to do. So I think there is need for more engagement and capacity building for all those that matter in the supply chain officers, the GILMIS focal persons, and to some extent, this also helps support
Yeah, so you raised
accessibility to medication.
So there's several excellent points within that. I mean, lots of things that we could pick up on. So, and one of the things, again, it comes back a little bit to engagement across the whole supply chain. So as you mentioned, which I agree with completely, is people need to know that neurological illnesses can be treated. Because if actually there's a perception, well, there's nothing I can do, then you won't seek healthcare. So if, for example, in dementia, for example, that may be considered a normal part of aging. So why would you seek healthcare if this is actually what happens? This is the physiology that is being enacted. And just as you were mentioning about stockpiling, there can be stock out, sorry, you were mentioning, there can be stockpiling. So in one of the other countries that we work in outside of the immediate IPINA program, there was an email that went out to all of the neurologists saying, please, can you prescribe levetiracetam? We have all of this levetiracetam that is about to run out in 1 month. But how much can you prescribe in 1 month? And if it's going to expire in a month, then how do you continue the supply chain thereafter? And the capacity building is also key at all levels, and making sure that and it's great that there are standard operating procedures, but like with any standard operating procedure, someone needs to know it's there. It needs to be in a language that is understandable for the person who is reading it, and people need to stick to it. So you can't have an SOP and then people just go off-piste and do their own thing anyway. So there are some really, really important points there. And it leads very nicely to the next bit about, and then we'll cast it open to the audience as well. So if you were to highlight one, I said we'll cast it open to the audience in a moment. Yeah. So you've got to keep the audience, on track, right? So if you could highlight one key bottleneck, like the one bottleneck, because we've highlighted several bottlenecks, right? But if you could highlight one, what would you say the most important bottleneck is? Again, not thinking about the whole system, but from your organizational perspective, what would you say the key thing is?
So the key thing for us is the tariffs.
Okay.
And sometimes the misinformation that comes with it. So for our tariffs, just as I said from the beginning, it is assumed that the tariffs are too low, and so practitioners wouldn't offer the service they have to offer to some of these people or victims who go for services.
Perfect.
Yes, and so the tariffs are low, which by God's grace we've advised, and it's a good thing. And then misinformation. We get clients go to the facilities and NHIA doesn't cover this. And so I would repeat again that we allow NHIA to cover what we cover. Please, once it's on the benefits package and medicines are allocated to it, we have DGRGs allocated to some of these things. You access, you give medication, you render the service to them, we pay you your claims. And so it's one big thing that we are struggling with as an authority. One, the tariffs, just as I said, and two, misinformation that we don't cover some of the services and medicines, but in actual sense, we do cover.
Okay, so that's great. So that's two bottlenecks actually, right at the end. So, but okay, so one, tariffs, and then two, misperceptions around, and that was around the tariffs and what might be there. And again, from a WHO perspective, we have one key thing, one key bottleneck.
So the prescribing levels at present that limits access to certain medicines within the levels of care.
Okay.
So there is a policy within the Ghana Health Service, the network of practice. That's what's going to operate as a hub and a spoke. Also, there will be a higher level that would oversee or supervise a number of lower level facilities. And that higher level can have the mandate to prescribe at the level of that higher level that can be dispensed at the lower level or dispensed to the lower levels. And that could have been a way of addressing some of these challenges, but at present is still in a pilot phase and is not fully implemented.
Okay, thank you. And it's always hard to be the third person in a list of three, but if you could highlight one other sort of specific bottleneck, the main bottleneck that you would suggest?
So I would say it's the limited capacity for the supply chain workers.
Okay. Okay, so that's clear. So then we sort of distilled like the three key bottlenecks, and then I'm going to borrow that microphone, if I may, and I'll pass this one to you. So we go into the audience, right? So Professor Sander.
Always there are going to be bottlenecks that are clearly known. There are going to be bottlenecks that are discrete, but can time to time come up. what's your procurement process for the drugs? And are they any sort of regional components, or is there a national? And how is that from the procurement down to the localities where the drugs are to be distributed?
So for us, the medications goes to the regional medical stores. Yes, so within the regional medical stores, facilities that are under can go and pick up from there. So the regional medical stores.
But there is a central procurement.
Yes.
And that, does that ever have problems? Does it is it, you will always have the procurement in such a way that it's not going to be a lack of medication at some point because, you have problems with the delivery or things like that?
Well, it does happen that there are sometimes shortages at the regional medical stores. Yes.
You want to?
I was wondering, maybe I'm not getting it right. The NHIA doesn't procure the drugs. It's the facilities that procure the drugs. And then they are reimbursed if they procure it by the NHIA. So the thing that we kind of found when we went around was not the stockouts with regards to the drugs by the facilities. And I think one of the major complaints had to do with one of the 7 A's of our Doomsday. The people that needed to prescribe it were not available to prescribe it. So if they even stock the drugs, it expires, and the same GHS will come back to them that why do they procure drugs that expire and not utilized? Because the person that needs to prescribe wasn't there. The person that needed it to didn't come. So the drug was available and it wasn't used. So at the end of the day, the next time they are doing their procurement round, they won't go for it because it wasn't used because of lack of a prescriber and a lack of a utilizer. So those are some of the things that we found in this our groundworks.
I also wanted to, it's very true. I wanted to add that in some of the lower primary healthcare facilities, they do not determine their consumption needs. And ideally, they should be able to determine consumption needs and then use that for their requisitions. So that is what informs what the facilities obtain. So it's based on consumption needs. But we found that a lot of the facilities are not doing that. Those that are doing it are also doing it erroneously, in the sense that they know the medications may not come. So sometimes they can just double or triple their needs so that when they receive the medications, at least they have something to take them through the period, which is wrong because your consumption needs informs it comes together to inform the national forecasting. So there's a big challenge on that aspect.
There's some very good points there because, of course, if you overstate your need, you're depriving someone else because there will be a limited amount of medication. And we mentioned a little bit before about forecasting. So the APINA program has a lot on improving diagnostics, and we were talking earlier this morning about if you improve diagnostics, you need to match that with better therapeutics. So if you diagnose more people, you're going to need more medication. But how do you make sure that demand and supply match closely? Okay.
Thank you very much, panelists, for the insightful presentations. I just want to find out, in our current dispensation for epilepsy drugs, I know the Mental Health Authority, their procurement unit also does a lot of the purchases. So is there duplication or there's cross-referencing, or is a free-for-all for epilepsy drugs, especially in the northern parts of Ghana where we did our first studies? They were depending more on donations from ADRA and co. So for the first 3 months, you get oxcarbamazepine, which is not available on that. And then there's stock out, then patients run out, then Phenobab comes, then there's another 3 months, no Phenobab. So it's a little chaotic. So is there any synergy between the Mental Health Authority and the Ghana Health Service? I know there's not much synergy between GHS and MOH, so we can use that for the Mental Health Authority and GHS in epilepsy drugs.
Yes, I would say there is. So apart from NHIS, nationally, anti-epileptic medications are also procured by the Ministry of Health under the psychotropic medication. And I have to say that over the years, this medication will go through the facilities, through the regional coordinators. And for those supply and distribution, it was challenging because now the regional coordinator was determining maybe with some form of an arbitrary calculation whether district hospitals should receive this amount of medication, health centers that amount of medication. But currently, we have an integrated system, which is the GILMIS. Unfortunately, across the regions, many of the key staff are not aware of this. And there are new SOPs for anti-epileptic medications under psychotropics that are distributed under the psychotropics to go through the same integrated system and the last mile distribution. But it's still a challenge. If you are focusing on a human being, a focal person, determining who gets, who does not get, what happens is that sometimes they are not even able to distribute the medication where it should go. And this leads to medications expiring in some of the regions. So it boils down to what I was emphasizing about the fact that we need to build capacity so that we all go by the integrated system that has been established. Thank you.
Thank you very much. I think Professor Sander had a follow-up question.
What's the sort of plan, the fallback in case that you identify shortages for any reason? Is that done centrally? Is there a mechanism that will, for instance, have a strategic amount of drugs to cover shortages? Or is this have to be dealt locally? Because I think that, Albert, we had this discussion so many years ago when we went to Tamale and they had run out of medication. And this was because there were some issues with, procurement. And it was a little bit, people were being switched from carbamazepine to phenobarbital, that's you. And then, back again when carbamazepine arrived. So I think that that's a very important because this is something that happens everywhere. The sort of, procurement sometimes, and there might be different models. Sometimes it comes from private distributions. Some countries will have a central way of doing it, but there always going to be something that goes wrong in the system. So is there like a process to cover or to deal with shortages?
I don't know who's best to answer that, but are there stopgap mechanisms so that if a given medication ran out and someone really needed it, then and I say that knowing that actually in many countries there aren't those stopgap mechanisms, and actually if the medication runs out, you just have to wait till the next cycle.
So from experience, within a facility, if you run out of a certain medication, you request to your regional medical stores. If it is not available, they issue with a certificate, a certain documentation that allows you to source for that medicine externally through suppliers. And so once you have that documentation of non-availability, you can ask people to, you can issue a tender for people to come bid, and then they can supply if they have it. And it will go through the local procurement of that facility or that at that level. And it should fit in what you are expected to provide at a level that you are providing for NHIA clientele as well as whichever clientele you serve.
And so when you do that tendering process, and forgive me that I don't know, is that now then going out to private tendering organizations? So, and how do you ensure the quality, the medication quality from those private organizations?
So there's a procurement committee, and then these private organizations will provide samples of the medications that they are tendering for. And the committee is supposed to look at who is best fit to be awarded a contract based on a set criteria, which will include quality, pricing, and other factors. Based on that, they agree on which is the most preferred, and then in that category, which is the next and the next and the next. And so when that happens, then they issue an award to the most preferred based on all other factors that they have listed. And then when it's done, the person supplies. If in some situations, they may decide that maybe the price at the point where you are awarding the contract, if the price for that medication has gone up, they may refuse to supply. And so that causes further delays because you have to maybe award to the next person who may either take it or not. And so when that happens, you have to go through the whole cycle again if you're not getting somebody.
So how long does that process take?
Oh, so for a typical system in a facility, it can take nothing less than, let's say, 2 months.
Okay.
And that is maybe when you have managed the process very well, because even issuing the tender, you need to wait for time for them to produce response that I have it and I'm providing the documentation and all that for the committee to sit and go through the process. At the national level, it can take more than a year.
Okay. So one of the things that speaks to is like if you have a 6-month cycle of your medication coming in, as soon as the first batch of medication comes in, you need to be thinking about the next 6 months, because if you think about it at 4 months, you're going to likely run out of lots of different things. Yeah. Okay. So now we'll ask the audience again a little bit. So I'm just going to ask the audience, who in the audience has needed a medication for something at some stage in their life? So if you've needed a medication for something at some stage in your life, just put your hand up. Right? So there's some people who've never needed medication for anything. All right, so I'm not going to go to them, but anyone who's needed medication for something, right? It doesn't have to be epilepsy, it doesn't have to be anything that you declare. From your point of view, what do you think, like from the demand side, what are the difficulties in getting medication? So anyone want to volunteer? Otherwise, I'll just choose people. Professor Newton.
Sorry, I'm on statins for hypercholesterolemia, and the dose that I'm on, 10 milligrams per day, I couldn't get the tablets because they were going to give me either a 20 or a 50 milligrams, but they didn't have the 10 milligrams.
Okay.
And so, the pharmacy was going to issue me with the wrong dose of the medication that I was on.
And did they suggest like cutting the 20 in half?
They did suggest cutting, but then they said I had to go to the prescribing doctor to get the dose changed so that they prescribed it.
Yeah, so thanks, Charles. So obviously that's a very important point about, because we haven't really talked about the dosing of medication And also in epilepsy, the type of the drug can be really important. So whether it's Tegretol or Tegretol modified release, for example, can be critical. But there must be other people in the audience who've had difficulties with medication. Yes, gentleman there, got the microphone. Oh, Patrick. Okay, yeah.
Yes, I think one of the things that I have realized is the dose. So if you're on, let's say, 16 milligrams of a medication, and in fact, okay, you are on 32 milligrams, and you 1 month the 32 milligram tablet is available. The next month you don't get it. Then you need to go get 2 of the 16 to make up your 32. And some of the challenges is the cost of the 32 and the 16 are the same. So then if you you need 32, it means you need to pay double what you were having before. And these things will still occur with many of our anticonvulsants, because the patients will come and tell, when I went, they didn't have any of the 200 milligrams, or so I needed to take 600. So then I needed to, all those confusion do occur because the way we still import these drugs and the way it is utilized by the facilities and the pharmacists who are looking at the profit margins that they are looking at. So there's always either you may have to increase your pill burden at additional cost, because the dose on which you are is not available at the time you are going for your prescription. And that happens to me a lot myself in my own way.
Yeah, so that's also a very useful example. It's because if the cost is per tablet, whatever the dose of that tablet is, then you can very quickly accumulate quite a lot of cost burden. And again, with carbamazepine, if you go, so someone's on 400 milligrams twice a day, they have seizures, you have to go up to 600 milligrams twice a day, but the cost of the tablets doubles, then that might be prohibitive. Okay, please.
One other thing for me I notice is when I'm going for a medication, just to buttress on what Professor Ajay said, I get confused between you can get this particular drug at this price for this brand, and then you can get this one at a lower price for this brand, and it all works the same. In Ghana, if you ask a lot of people here, a typical example is paracetamol. Some of them you can get it for 1 cedi, and people classify them as chalk, mere chalk. There are some you can get it for 10 cedi, 15 cedi, which is expensive. That is what most people go for, because there is this perception that if I go for this particular one, it is of some level of quality. And mind you, it actually works when you take it. And when you take the lower one, you don't feel it's working. So it's something that I see as a difficulty as a potential client that goes for medication. This confusion in which brand versus the price and the quality that also comes around it. Thank you.
Yeah, no, thank you, Daniel. So I think that's also an excellent point, because on the demand side, perception is very, very important. You know, what do you perceive is going to benefit your health? So my wife's family are from South Africa, and in South Africa, less so now, but if you went to a doctor and you didn't get an injection, the doctor's no good. You know, it doesn't matter. You might have like hurt your toe, but you have to have got an injection, you know, otherwise go back, see another doctor, right? And so the perception as to what is actually good medicine, what is a good drug, and it applies everywhere. You know, look at car brands, for example. We buy like a certain car may be absolutely fine, but you pay double to get the brand on the car. So that's also great. Any other comments from people who experience things in their own lives in terms of medication access and so on and so forth? Okay, but one thing that we're going to have to do, of course, is like match demand to supply. So we talked a lot on the panel about what are the bottlenecks in terms of supply, and this is a little bit about what the perceptions are and the difficulties are in terms of the demand. And so bringing that together, so for everything now, there's a digital solution. Yes. So what would you, if we move now from the challenges and the gaps and the bottlenecks to the solutions, what are the kind of things that you think we should be doing to try and solve some of these difficulties, please?
I think I have mentioned one already. For NHIA, from where we sit, to increase our benefits package to cover most of the new trends in neural conditions, to absolve some of these conditions and medications that come with it. And so well noted is one thing that talking with management coming here, we envisage to do to expand the benefits package to take into or list and onto it some of that coming up and the medicines that we do not cover as NHIA to accommodate them. Yeah.
Great. Thank you. Okay, and then with a digital lens again, so there's specific things that you think might be particularly helpful?
Okay. So I think it will be important to digitize our supply chain system. And if it is available, we strengthen the gaps to ensure that we are able to get the data on how medicines are distributed, whether it's centrally to the service users, and getting returns at national level to inform purchasing and procurement processes. And then again, to strengthen or create an enabling environment for local production of medicines, which will include what we use in epilepsy and other neurological conditions. Beyond what we can locally produce, we need to also look at pool procurement, where we can beat down prices because we are buying in bulk, whether as a country or liaise with other countries, to be able to negotiate favorable prices to ensure we reduce the costing for medication and ensure that it's affordable.
No, that's terrific. And we just on that though, just before we move on, because we talked just very briefly yesterday about local production of medication and a little bit as to whether that's always viable. I mean, no country will ever be able to produce all the drugs that are needed in that country, whichever country it is, except perhaps the US, perhaps China could be, and India, because India likes to make all of the drugs. So but regional, there's a lot of power within a region and like collaborating within a region and actually breaking down the barriers across different countries and saying, well, actually, we could do this together. Do you have any further thoughts on that, or is that what you would you recommend regional or local?
So regional would be best because then you can have numbers to negotiate for prices. So if we say we are partnering with Nigeria with their population base for certain medications, that will be a force to reckon with, and that will give you the advantage to negotiate for prices because you would have the volumes that will at least will make you be able to make a case.
Yeah. And the key thing on that, of course, okay, Len, before I say
before we get into production, we need to actually talk about licensing and how drugs are available, because that's the... So, for instance, if there is an antiepileptic medication, let's put it lamotrigine, that needs to be licensed in the country before importers can bring it or the national system can look for it, or can it be done without a local license? How does that work? And that's, I think it's an important, because that will put that will change the game. Because if a drug is licensed in the country, then different companies can bring in generics, for instance. If it's not licensed, someone that wants to do it on an official way, they will have first to get a license. But that doesn't apply to all countries. So how does the system work in Ghana?
Medication that's being brought in or produced has to be licensed by the Food and Drugs Authority.
How does the process work? Is there for instance, a manufacturer has to apply for the license, or can, for instance, a distributor or how does that work? Does that actually
I think it's both ways. If
both
you're
can apply?
manufacturing, if you're bringing it in, you still need to get that license to be able to either produce or to bring it in.
Okay. Thank you both. And so again, so solutions from a digital perspective, again, from an organizational viewpoint, I guess, and you kind of talked a lot about task shifting, task sharing really, rather than task shifting, but how could digital solutions possibly help with that?
So currently we are using the Ghana Integrated Logistics Management Information System, the GILMIS, for the requisition, and that also informs the consumption needs, forecasting and supply planning. And then when it comes to distribution, we use the last mile distribution for the medication from the regional medical stores to the facilities. And I think that this system needs strengthening. And for all the key individuals in the supply chain system needs their capacity to be built on the policies and the guidelines that support accessibility to medications. So we know what to do when there are stockouts and what to do so that we go with the cycle, because it has schedules that affect facilities when they are missed, and it's one of the contributory factors to the stockouts of medications.
And I guess also with task sharing, with now everyone is much more familiar with Zoom and Teams and stuff, you can actually do much broader training, you know, from central locations. Nothing substitutes in-person meetings like we're having today.
To reduce the import duty of the drug that they're supplied. While if we were to try and get, for example, drugs from South Africa in Kenya, it is much more expensive to get drugs from South Africa than it is from India or China. And it's just because of the sheer volume that they are producing in the context of what's been imported into the country. And I don't know if that's the same here in West Africa or not.
Any insights on that as to where does a lot of medication come from India? And
yeah,
and most of it, yeah. So, but
I think that there is no economics behind the idea of regional manufacturing because of the issue of volume. You know, the drugs will have a cost according to the volume. So this idea was was a lot of discussions, was started by the PAO about 20 years ago. But then they themselves decided that that was not economic. And the idea at the time that they would create 3 regional sites to manufacture drugs, and it was not antiepileptic drugs, was for other indications. But then because of the volume issue, the Indian solution became quite apparent, although there is still some parts of the WHO bring this up and up. But what should replace the idea of regional manufacturing should be regional procurement, because you know you will get better cost savings if this is procurement is done on a regional basis. So you could have a consortium, and I can't remember which countries in Central America for some conditions they have a consortium that they acquired. It's not for epilepsy, but they acquired like a number of drugs that are acute drugs, and they outcome and they're then distributed. So this has problems as well because you know government in one place changes and they don't like the something how it's done. But that would make more sense from an economic point of view because nowadays there are 5 countries that make almost most 80% of drugs, and they are China, India, I think it's Mexico, Puerto Rico, and Brazil. And in Europe, most drugs will come either from Hungary or from Croatia and Slovakia. So these are the places that drugs are made. So if you can get them there, because there, as you said, it is the volume that will bring the price down. So an idea, and of course, if you start with regional procurement and how this works, then you can start thinking about regional manufacture of certain drugs that you could get an economic case to make them. And that then could create facilities that can expand with time. But initially, I would think that, and I would fully agree that, regional efforts, procurement rather than manufacture, is a way forward. In a country that has 4 million or 40 million people, the volume of sales of a drug will be corresponding to the number of people you have. But, to make a drug economic, to pay itself, you need something like 400 million, for instance. So this is why you have these issues with the manufacture of drugs. So you need to think, we cannot actually let the patients run out of medication. We need to provide them at the first place, and we need to find ways that we can do this in a sustainable way. And, if you manufacture a drug, for instance, and the idea of lamotrigine costs 200, but you need to see the capital expenditure. To put a factory up means that you're probably going to be ending the per capita expenditure on health for 20 years for the whole country. So these are the sort of things you need to think about. And I have seen many countries where they come up with the idea of let's manufacture the drugs ourselves. But that's not really, it doesn't make any economic sense. And we need to think that in health, a cost opportunity is important. Because if we expand on something, we are probably depriving loads of people of health. So it's very important that we keep the economics in mind when we do this.
Yeah, so that comes back. I'm going to use this word, pharmacoeconomics. So because it does come back to that, and obviously what's happened in the last 20 years, I feel the entire burden of India on my shoulders. But anyway, is that the competition in India pharmacology is vast. So not only is it that they can supply at volume, but there are so many competitors that if a given company won't supply it, there'll be 10 standing up who will take on that new drug and be able to make it up very quickly. And even drugs that are not yet generic are now being a slight tweak and a slight variation of that is all being manufactured at scale in India. So I guess the regional manufacture argument was to avoid taxes, because if you had them more locally, you would avoid all of the import-export duty. But perhaps regional procurement is certainly one way to do it. And of course, regional procurement, anything regional, whatever the region, if it's Europe, Africa, America, wherever it is, requires a lot of political will. You have to have a lot of political buy-in from all of the countries that are going to constitute the region. Okay, so we said it's very important we have some action points. So before we distill all of this through, firstly, any other questions from the audience? Anything else anyone wants to
Just
ask?
a little contribution to just what was discussed.
Absolutely.
Yeah, just as much as I'm in support of local production, like you're saying, it doesn't make economic sense to produce all. Yes, so definitely the point you made about pooled procurement will be very helpful. But in that vein, what we should be looking at is a policy to help us clear off some of the taxes, because that's a big challenge in the country. Sometimes even program drugs come to the port, and getting them off for patients to use is a challenge. So the policy around how we handle our taxes in terms of pooled purchases or program drugs should really be looked at.
I think that's an excellent point. Unless you can actually get the economics right, you will not get buy-in from the people who can actually make the change. Yeah, it's critical.
Just want to put one span in the works. So one of the problems with that has promoted, for example, vaccine development within Africa was the fact, for example, during the COVID vaccine, although the COVID vaccine was being produced in India, it wasn't being shipped to Africa because Africa was way down on the list of regions that were going to get it. And so there was a big delay in terms of rolling out the COVID vaccine in Africa, mainly because it was being utilized in other regions first and foremost before it was being shipped. And so the CDC in Africa have really tried to push ahead about developing vaccine development within Africa so that they have first bite at the cherry rather than being at the bottom of the.
And obviously there needs to be a duality of approach. We need to sort of see what the best way is to approach it, both in terms of regional procurement. There might be things that are very good for local manufacture even to try and ensure sort of health security. So, okay, all right. Any other, because we're going to have to wrap this and distill this into like key action points. And like there's this acronym called SMART, which is specific, measurable, appropriate, relevant, time locked. And I have SMARTs because they had an S at the end, so you need a specific person who's going to do it, right? Because otherwise you'll just say, we'll say all of these things, we'll meet again, it'll be very pleasant in 2 years' time, but we've got to move the needle, right? So any comments, because we're going to distill the priorities together, but anything else from the panel that you would like to mention at the moment? Happy? All right. So okay, so in terms of then the priorities, so specific priorities that you would like to see. I'll ask you guys for one each, and then we'll add the MART after it. But you mentioned tariffs several times. Are you going to stick with tariffs? Okay, tariffs, right? So, and Mercy and Sabina, you're getting this, sorry?
I was saying is the major thing that providers keep complaining about.
Okay. So if you were to distill that into an action point, right? So what specifically do you want to happen about tariffs? Oh, sorry, you'll need
the annual review of our tariffs.
Yeah.
Yes. To meet economic needs at and when.
Okay, so that's the specific aim, right? So measurable, because that's what we're going to do, is like actually look at the annual review of tariffs and make sure that they're appropriate. It seems appropriate and relevant for sure. And then how long to get all of this completely lined up?
So we do it annually.
So within a year?
Yes.
Okay, fine. All right. So that's the first priority. Second priority, WHO priority?
So as a technical agency, we support government with relevant policies and guidelines. And so usually we work on what government prioritizes. And we know that government is prioritizing NCDs, which includes what we are discussing. So we would support government in terms of technically what they need to put in place to ensure these policies work.
Okay, but a specific thing? So what are you going to say is there's a specific thing that this group should try and do over the next 12 to 18 months?
Well, I think that what we can do is advocacy in terms of getting government to, as it has prioritized NCDs, which includes neurological conditions, ensure that every stage of the discussion, neurologic conditions are on the table and whatever actions are happening in the NCD space, whether it is access to medicines, whether it is in terms of funding, in terms of awareness creation, whatever, we have a foot in the door.
Okay, so if we say there's a specific point to meet with government to try and showcase non-communicable disease for sure, but specifically neurological non-communicable disease from a medicines access perspective, and then we will do that within a year, let's say. So, okay, all right. And then the lady at the end, so specific aim for the next 12 months?
So I would say strengthening the supply chain system.
Okay.
There should be further engagements and capacity building centrally through to the regional medical stores to the facility level, all focal persons involved.
Okay, so that's terrific. So the specific aim is to improve capacity building by an enhanced task sharing. We'll measure it by the number of people that we've trained. Yeah, it's clearly relevant and appropriate. And within a year, then we will do that as well. Yeah, okay. All right. So we're taking your names across all of these tasks because there's got to be someone specific that does it. Any other specific aims from the audience? Anything anyone else wants to add? All happy? Looks all happy. All right. So,
Okay.
lady at the back.
Yeah, thank you. I want to comment on the medicine, the manufacturing bit. I remember some years back for antimalarials, for example. I don't really remember the name of that program, but I think it was like affordable medicine, AMRF. I'm just using this as an example where, yes, where there was, what's the name again? When there was that collaboration, I mean, or the local content manufacturer, I remember Dampo Co. as a pharmaceutical company, and it made for us clinicians at the time, I mean, medication was available, readily available treatment. So I think we can still go on with that. Yes, this is my view. I also want to contribute to the issue of the supply chain building. That is very important. And this should really, really be given good attention to. Why? Because periodically there's nutrition at the various levels becomes a key challenge to managing even the GILMIS, the software. So today you train this person or this officer is working on it, but that person goes on transfer, and from like the first insertion of the system trainings and all that, there hasn't been consistent training of the officers who handle this thing. So that in itself creates patient could be up at the regional medical stores or the central medical stores, but through the system, how to request, do the distribution, do consumption becomes a problem. And that is the data being used to plan and to focus for the buying. So that should also be given a key look at, just adding to what the panelists said. Side is also the last mile distribution. And that I also want to advocate that we take a very good look at the players in that sphere. Why? Because you look at a district, a typical district, the last mile could come and release, regardless of even working through the GILMIS and making these requisitions, they can come and leave the medication or the items at a centralized point. So the end user in Lekbono who needs this medication or Agoto, although the medicine is in the district, the anti-epileptic is in the district, but it's been dumped at the centralized point. But that is not the reason for which the last mile distribution system has been instituted. So I'm giving this as a feedback to you and also to all concerned that we have to look at the players in that sphere as well. Thank you very much.
So thank you. There's some excellent comments there, and we should certainly learn from other disorders and what's been done in the past. The capacity building and task sharing is critical. And the last mile distribution, we didn't really talk about that, but we can add that as an action point, because one of the things we could do for ensuring better last mile distribution is community engagement across like both the facilities and the local community so that actually things join up, so that again people know that there's medication available and where to get the medication they should get medication. So that would seem like a fourth good smart objective. Okay, so I think we will probably then, unless there are any other comments from the panel, no, all happy? Yeah, and no other comments from the audience, then we will conclude there, I think, and then we'll take this forward and try and bring those action points to bear fruit. So it only really remains for me to just thank the panel for all of their valuable insights and for participating and taking on board all of the questions. And thank you to all of you for your attention. Thank you.
Thank you. You can take it here. Yes, please. The panelists and the moderator, you can take a group picture, please, just in front here. Let me be out of it. I'm not a. You're good? So whilst the pictures are being taken, I'd like to make this brief announcements. So we're going for snacks. We're going for snacks, and we'll be back here at 11:45. Snacks are ready to continue with the workshop. And in this, we would like to see some of the key, hear from our technical people, and also to know what progress has been made from 2022, the first meeting we had. So we would have to ask some key questions around that, and we hope to get information on how we have moved forward from 2022 to now, and then what we can do going forward. So please, it's time for snack, and we'll see you back here at 11:45. Thank you.
No, so after your
Hello, hello, hello. Good afternoon again and welcome from snack break. So I would want to give a bit of information. We are tweaking the program a little bit to be able to make way for more discussions on the next segment. So we were to do a workshop right after this on access to treatment and medicines. But the technical group feels we've covered much of that particular area. And so we would want to move on to the next so we can allocate a bit of time to discussing that. And so bear with us for the change in the programming. So the next we are going to discuss is on data management, monitoring, and evaluation. That's our next. And this session will be chaired by the co-PI for Ghana team, EPINA team, Professor Albert Akpalu. He's going to share with his panel members. So the format is Prof. Akpalu will give us his remarks from the beginning, and then we would introduce to you our panel members who would have the discussions. So ladies and gentlemen, please, with a round of applause, let's welcome Professor Albert Akpalu.
Thank you very much. And I must thank the EPINA main core team, Charles, Lee, Arjun, and Helen, who have been with us. I think we've been doing this for quite a while, for especially Charles from Kintampo days. And then, so we've all been trained and mentored by Lee, Charles, Arjun, and Helen. So I'm not here on my own rights, and I acknowledge them as our mentors, and they've been here several times. So thank you very much for coming back to Ghana, join Ghana. Thank you. So we've been talking about this. We're talking about data and monitoring of care for epilepsy and other neurological conditions and implementation of the IGAP. WHO is very passionate about the eye gap, but there are problems in the implementation. So I think that is one of the things we are here to discuss. Data currently and monitoring are very touchy issues in Ghana now. Let me see by hands those here who are using the GIMS platform. The GIMS. Okay, I can see the smiles on your faces. So there are problems. We used to have LIMS in Kolebu, and the Ministry of Health Facilities, that has gone. GIMS has come. As at now, I do not have GIMS on my ward, so I have to write. So we are losing data for our patients with epilepsy. So that is a very serious issue, and I think this is across the regions. A few regions are fully on board, but most are not. So that is a big problem of monitoring and then data. So I think I have a few questions for our panelists when they come. For Ghana Health Service, how are we monitoring our epilepsy data? Is it through the Mental Health Authority, or we have a separate program? Before, when EPINA was in, before EPINA, when we're looking at the SEEDS project, we had a program manager at the Ghana Health Service. I think that has been put under the non-communicable disease division. Am I corrected, or that's the truth? The Ghana Health Service, the psychiatrists are looking at me. Is it the truth, or it's been disbanded? A technical is NCD and mental health. So we have advocated in our recommendations that we should have a separate program for epilepsy, but I think that is also something that we'll discuss on the panel, the discussion. So monitoring of and implementation of the IGAP. There's been a lot of training, there's been a lot of workshops, but can we be rolling this out at the regional, district, and at the CHIPS level? What's the capacity of the staff we have to implement this? Because if you look at the IGAP, especially the epilepsy part, there are some technicalities in terms of who can manage what. I'll give an example. When we went to Tamale, we were trying to look at who manages status epilepticus when somebody's having constant seizures. And we went to a district, and the medical assistant, I think it was a PA, said he gives his Valium IM, and nobody is going to change that. And when, I think, was it Lay, myself, and Patrick, when we tried to stop him, he was like, who are you? This is what we do here. So how do we change the mindset of such people? So I think that is some of the challenges that we have to look at. So looking at the perceptions, challenges, and opportunities affecting access to medicine and care in Ghana. So my panelists today are Dr. Adjoa Kusi, again from the Ghana Health Service / Mental Health Authority. I've added that to her because she's a psychiatrist, and I happen to train her as well. So I'll add that. So Adjoa, you're welcome, please. We also have from the Ministry for Service Provider, Dr. Mamata. What's her full name? Okay, right then. The name. Okay, Dr. Patience Ami Mamata, who is the director at the Ghana Health Service. She's a service provider, so she'll answer all our questions today. We'll be very gentle, so you take good feedback. And then I'll call Dr. Augustina Chawe, who is the treasurer of the Neurological Society of Ghana. She's the immediate past president of the African Neurological Society. So she has a lot of experience to share with us. And then I'll call Dr. Edina Nai. Is she Dr. Edina Nai? Dr. Edina Nai, yes, from the Ministry of Health. From a Ghana Health Service. Okay. So Ghana Health Service, Ministry of Health, they are brother and sister. Fraternal twins. And then, so 1, 2, 3, 4, 5. And then myself. So we're going to kickstart. So maybe I'll let each of them. Okay. Thank you. Here. Okay. Let me take that mic. Okay. So I'll start from reverse order. So, Dr. Nai, can you just tell us a little about yourself and what you think our team is about? Or what you think we can comment on the team, perceptions, challenges, and opportunities affecting access to medicines in Ghana. So everybody will give a brief comment and then we start the discussions.
Okay. I'm Edna Nai. I'm a pharmacist at the Ghana Health Service Pharmacy Directorate.
I think the mic.
Hello?
Yes.
I'm Edna Nai, pharmacist from Ghana Health Service Pharmacy Directorate. And I think this team is very key if we really want success in the management of epilepsy in Ghana. Without medicines, we can't achieve much. Medicines are the bedrock of all our treatment. So having access is very, very key. And from the previous discussion that has been made, we can see that moving forward, we can only speak to data. Data is the new gold in our era. Without information, we can't say much. So it is very critical that we have data, we have it accurately, and we have it timely, so that we can make the necessary policies or inputs into the management. Thank you.
Good afternoon once again. My name is Ajwa Kusitre. I'm very happy and privileged to be part of this panel once again to discuss this important topic on data. We all know that the quality of data matters, not just about the data that we collect. And I think from my experience and from the supervisory visits that I've had opportunities to participate in, when it comes to data, our main challenge are the quality issues. In terms of validating the data, collaborating with key individuals who matter within the programs. So I'm happy to contribute to this discussion once again. Thank you.
Good afternoon, ladies and gentlemen. My name is Dr. Chawe Feli. I'm a neurologist. As Professor Kwalu has informed, I am the treasurer of the Neurological Society of Ghana and immediate past president of the African Academy of Neurology. But most importantly, I am simply a neurologist. I work in the 37 Military Hospital, which is a quasi-governmental institution. Unfortunately, we're not part of the Ghana Health Service, but we do function as a public institution. We see anyone who walks in through the doors. So we very much see the challenges that the other public institutions have. From my bell tower, as a specialist, as a neurologist, to me it's extremely important that education is disseminated across all levels, from primary health care all the way up, and then ensuring that there is adequate communication between the different agencies that all come together to ensure that the patient gets what they need. Because it is unfortunate if a patient goes to see a doctor or even a physician assistant. The physician assistant says, this is what you have, hopefully correctly. Again, training, the ability to recognize these problems. The physician assistant says, I cannot prescribe XY medication because the facility you're in, you cannot get it. So I think these are things that we need to look at so that it is not the patient's responsibility to be going to the right facility, but the provider's responsibility to make sure that at every point of encounter, the appropriate care is given. And if it is not possible at that level, again, it is the provider's responsibility to make sure that the individual knows where to go and facilitate going there. And then, of course, documentation. Unfortunately, historically, I think that's the thing the best at. But again, through adequate education, properly documenting, and then making sure those documentations and the data that comes out of the documentation reaches the facilities and the agencies that it's supposed to. Thank you.
Good afternoon. My name is Patience Mamata, and Prof. Akpalu, I'm not a doctor. I'm in charge of Ningo Prampram. I work with the Ghana Health Service as the Municipal Director of Health Service. My experience with epilepsy, I just want to share this with the House, dated back, way back in the Volta region when I was in class 4. And what I remembered was a classmate of mine in a school that my father was the head teacher. All of a sudden, it was about break time. Then he just fell and started fitting. And at that time, everybody we all got scattered, the teachers, everybody, and I observed the jerky moment and all that. I remember it, I mean, this is a class 4 child, and it's, don't touch him, the teachers, everybody. And he laid there for a number of time and went through all the phases. Then later, he got up and he was asked to go home. After that, being a village school, we were asked to gather thatch, which is used in roofing. So that was bent in the classroom where he fell. That was what I remembered growing up as a child until I came into the health professional working in this space. And my understanding, I mean, as the Bible may say, was awakened or whatever. What does this tell? That's why yesterday, for example, the issue of advocacy downstream, because these are teachers, students, among others, need to know the condition and that it's not contagious, that you are touching anybody or you are sharing fomites or anything. But to do all these things is driven by data, or must be driven by data. And from where I sit, we made sure that whatever data is being generated from the facility level, from the community level, as regards epilepsy, is entered into the DIMS, the District Health Management Information Management System. And we go ahead to validate this data periodically so that it can be used in proper decision making, even as we were discussing a while ago about medicine availability and access, among other things. So in brief, this is Patience Mamata. Okay. Thank you, Prof.
So Patience, thank you. So I think the Patience really carried off this discussion. So the DIMS, that's the District Health Information Management System, is where the data is entered. So for us, how do we monitor care for epilepsy? So there are various things we need to look at: treatment gap, the continuity of care, availability of medicines, and stigma-related outcomes. Going through the processes that we've had, what measures are available on the systems that we have? So I think the Ghana Health Service.
Thank you, Prof. So as Prof has mentioned, we have the District Health Information Management System, the DIMS2, which is used to report on epilepsy and other neurological conditions. At the facility level, it follows the ICD-10 classification system. It's still undergoing review to move the classification of the disorders to ICD-11. But currently, we use the ICD-10 classification. So at the facility level, the healthcare provider is able to choose either the provisional or final diagnosis, and that is entered into the DIMS. I must say that depending on the level, you have a certain level of access. If you're a healthcare provider diagnosing versus a manager monitoring and supervising. The Ghana Health Service structure follows a certain monitoring and supervision structure where the regional supervisors have supervisory oversight over the district and the district, the sub-district level. So if you are a manager in the district, you have access to the DIMS and you are able to monitor the various forms. So there are different forms under which the data is collected. And it's able to give you cumulative or summary information that you can make informed decision from. If you are a manager at the level of the region, you have access to all the facilities in the region. And from the facility level, moving up to the district, regional, and national levels, individual data are accumulated and reported on monthly basis. So right from the monthly data on the forms, you can access the preceding month. So for example, we are in February. So you can access monthly information from the DIMS for the month of January. And then, of course, you can also do for previous years. If you are in the districts, you have access to all health facilities in your district. If you're a manager at the region, all facilities at the region. And if you are also at the headquarters and national level, you have access to data for all the regions. And I must say that it's this data that informs decision making, helps us know where the burden is and where the issues are. Thank you.
Thank you very much. I think we have a new addition from the WHO rep, so I think we are getting an extra chair, so he will join us. So I think this is very good information. So at the district level, so for us at the Ministry of Health level or at the quaternary, we don't have these systems. So how do we integrate? How can we integrate our data from, let's say, our epilepsy clinics at Kolebu, Rich Hospital? Rich Hospital is under the Ghana Health Service. So, but I've been there. They do not have that integration facility to what the district is doing. So the question is, what data are we using, or what data are we procuring, or what data are we churning out to make the decisions that we are doing?
Yes. So for your question with regards to Ridge, because Ridge Hospital is a facility, they are not, it's the Regional Health Directorate and the Regional Director of Health Services and his management team will have access to the facilities in the region. But if you're a facility, then you have access to facility level data, maybe following up on patients and stuff. So I think that's maybe why you had that challenge with Reach Hospital.
Yes.
I think your question, if I got you right, there's a data gap between teaching hospitals and Ghana Health Service inputs its data in the DIMS, but teaching hospitals are not inputting in DIMS. So I think that's where the challenge is.
Thank you. I forgot that question. I have to say that I've been in multiple stakeholder meetings with the CHIMS directorate. They recognize that challenge, and there's been a lot of discussions and work on having that integrated system where we can also access LIMS, for example, have that integration. So I believe work is ongoing on that.
So, for example, where I work, we are also not part of the Ghana Health Service, so our data doesn't go anywhere. But I think perhaps we leave, or maybe we don't leave, but we consider how the teaching hospitals, the quaternary institutions can still be standalone, but there needs to be some kind of reporting system where this data is sent regardless of whether you're part of the system or you're not part of the system. Because a lot of the private facilities also have data up. Patients don't always go to a public facility. So if there was a reporting system between all the facilities that are not necessarily under the service, but perhaps under the purview of the Ministry of Health, that information can be adequately collected. Because I think the biggest challenge that I see in my practice is number one, the referral systems and the communication between a referring site and the referee site. And also this kind of information, feedback, etc. And if there was some kind of network where we could all be participants of that network, we don't have to have access to each other's records, but we have a network where we report all the data that is required. Because that data is information for the Ministry of Health, regardless of whether the source is governmental or not.
Okay. Good. Yes. And inputs from an end user. Okay. Can you use mine?
Okay, thank you. Just want to add to what Dr. Chawe just said. As regards private facilities in a particular district, municipality, or metro, through the DIMS, we capture their data. We capture their data into the DIMS too. So once that facility is working with that, we capture their service data, including epilepsy, etc., which then goes to CHIM, which is the Center for Health Information Management System. So once that facility is within the district and working with the directorate, we capture their data. Thank you.
Okay. So thank you. So before we continue, we have our WHO rep, Dr. Ernest Konedu Asiedu. So please let's welcome him. And for the Ministry of Health. Yes, from the Ministry of Health. So my apologies. So we've been talking about access, data, monitoring of care for epilepsy, and we've seen what the Ghana Health Service is doing. What is the Ministry of Health's view of that? Before you came in, I said the MOH and GHS are brother and sister. They are fraternal twins. One came holding the other's leg. So
it's father and daughter. Since the panel is only daughters. Okay, thank you very much. So generally, the ministry is the policy arm and has currently almost 30 agencies and associates that we work with. Ideally, the District Health Management Information System 2 that we have is supposed to be the data repository for all the data that is collected in the health system, both public and private. The challenge is that because it was viewed as though Ghana Health Service was holding it, we had some challenges with private sector not reporting some private facilities not reporting into it. But the district directors are empowered to ensure that every facility within a particular district is supposed to report into it. Similarly, the teaching hospitals are also located within a certain district. They are located within a certain sub-district and are even found in a certain chips. So teaching hospitals are also expected to report into it. But because during the split in 1996, when the service was supposed to have been formed, and at the time, two teaching hospitals, were able to lobby and force their way through to ensure that we have the Teaching Hospitals and Ghana Health Service Act, the 525. But ideally, we are supposed to report into it. So when the LIMS came, which was more of transactional data, that gave the opportunity where all facilities, were using. And currently, with the games also coming on board, all facilities are going to report. We were working with HIFRA. One of the mandates for HIFRA, especially as regards to assessment and monitoring of health facilities, also exposed that if there's a facility that is not reported into the DIMS, then your renewal becomes a bit of a challenge, because what service have you been providing over? We know Kolebu Teaching Hospital is providing some service, but if their data is not made readily available in the repository that we have, then it's as if. So I'm very happy that you raised that issue around the data, because we use the data to make decisions. For example, we are going to have, let's say, a holistic assessment tool, and the ministry is typically every year does the health sector medium-term development plan. A chunk of the data is coming from the DIMS, and the DIMS is typically limited. And now we bring the teaching hospitals, the Christian Health Association of Ghana, Media, reports holistically into the DIMS. But the self-financing and the Ghana Association of Quasi-Health Institutions, like 37 military hospital, police hospital, the prisons hospital, and many other VRA, and some of them might not necessarily readily report into it. But the mandate is that if you don't report into it, then monitoring and renewal of license becomes a bit of a problem. But now that we know data drives quality of care, and everybody now is beginning to see that this is what we need to do, we are ensuring that everybody is reporting into the DIMS so that we can use that information to make decisions that ultimately will benefit the population.
Okay. Thank you very much. I think that's a very good intervention. But let me bring a works. How about the private facilities? Because private facilities take up about a third of the healthcare practice. So they don't necessarily input any data in it. So I think that's a gap that we need to look at, that we have to address.
They do. A number of, maybe I would say about 2/3 of all private health institutions report into the DIMS. Because that is why HIFRA was mandated to ensure that if I'm going to renew your license, at the beginning, yes, but the district directors are mandated to ensure that once you discover a facility in your district, take steps to. It is also related to the intention of making profit. So typically we say the self-financing are the ones that should make a little bit of profit. The idea was engaging the service of a health information officer who needs to be trained to be able to make inputs into the DIMS was not one of their priorities, because it doesn't really generate income for them. And so in the past, the district health information officer would have to be going to some of these facilities. And it was like, it is the burden of the district director. So you have to send your people, go when they like, they give you the data. When they don't like, they don't give you the data and all that. But it's now mandatory. And within the HIFRA assessment tool, if you don't report, except that closing it down because of that is like the chicken and the egg, where, they are still providing some service. But we are working to ensure that every health facility in the country reports into the DIM so that we can capture the data as such.
Okay, thank you. I think this is answered a lot of the questions I was going to ask, because the next question to the panel is that who should enter that data into the system? So we need health information officers. What is their caliber? What is in your district? You have health information officers. What is their caliber?
Thank you very much, Prof. So health information officers are officers that are trained in biostatistics or data management, some with diploma, some with degrees, some with master's degree. who continuously look at the data and coordinate all activities that are related to health data in the district. So as Dr. Asiedu was saying earlier on, they form a focal point. Even when we have to go in to train private facilities in the various data sets that are expected of them to be submitted to the directorate or through the DIMS, it is health information officers and the ACADA that take the lead in this. As a director, you maybe visit the facility with them, interact with the CEO, and also introduce them, tell them of our mission, and also give them the necessary, at times, the registers that we have available for them in the data capture. We also talk to them to have access to, most of them use softwares. And some parts may be compatible with our data reporting format, some are not compatible. But we are able to talk to them to be able to bridge this gap. At times, they will have to print out, we have to do manual extraction and all that. So this and others are the works of the health information officers, and it's very critical. We also offer trainings for them. At times, the private sector may also engage an officer or somebody, and we are able to train those people to manage their data and also grant them access to do the entries, which we validate anyway. You have to submit and we validate that the data is of quality. Thank you.
Okay. So thank you. So I think this round of question now comes to the audience. So how frequently is this data gathered by the Ministry of Health? Is it every 6 months? Is it quarterly? And how is it generated into policy action? I think that's the gap that we are discussing.
Thank you very much. So the data collection it happens as and when, because it's web-based. The DIMS 2 is web-based. You can't, in the past, the DIMS 1 was, you could work offline and upload. But this time it's web-based, so you need access to internet 24/7. And it's all about access that is given. So for those who generate the data, they have access to be able to enter the data in the facilities. And at different levels, I think one of our colleagues was talking about it, that depending if you're at the regional level, you may have access to viewing the data and to be able to prompt that there is something. For example, because it's web-based, if the internet, the bandwidth goes down a little bit, maybe you were pressing a mortality of 1, then you pressed, you didn't see, you pressed another 1. It may later on appear as 11. People at the district level who cannot touch the data but can view it, another level, regional or national, may see that, 10 mortalities in a month, raises a lot of concern. And quickly they have to call back, and then they call you in the facility, then you realize, no, actually it was 1. But because the internet was a bit slow when I pressed these are. So the ministry also has access to viewing. Depending on your level, you may have access to seeing all the national data that comes, or depending on your level, what you are supposed to see. And we see it every day. And then ultimately, this is compiled every month. It's compiled every quarter. The ministry organizes a quarterly review, half-year review meeting where facilities, present. And one of such meetings typically is the health sector technical working group meetings where they discuss. And that's where we're even coming from. But this time they were discussing the health sector medium-term development plan for 2026 to 2029. So we are looking at this. And then during the health summit, there is an opportunity where holistically we look at what we call the holistic assessment to some of the data that is teased out and what the health sector medium-term development plan prioritizes that we need to look at. And then this is shared with the entire health sector and other non-health institutions that come. So the data is readily available to us every day, and we use it as such. Thank you very much.
Okay. Yes. So, Lay, please let's get the mic. Yes.
Just trying to understand this. The system covers all health encounters, not just epilepsy.
Yes.
Yeah.
All.
And the main purpose of it, when it was set up, is for administration, quality management, or research or a mixture of them, because they all have slightly different nuances. So I think that, how many hospitals you have here or this units in the system?
So basically, the data that we collect, this is service data,
Okay.
which must inform policy,
Yeah.
which we use some for research, and then for any other thing that is important. Of course, when you put the, sorry, go ahead.
No, do you understand? So you have the basic information, but if a researcher wants to come and in-depth research something, they would have to go to the patient notes or individual databases at the unit.
So we have two systems.
Okay.
The one we use for the electronic medical record system, which we use for transactional information, where a patient comes and the clinician takes the data, it's lodged.
Yeah,
For example, we used to have the
transactional,
LIMS,
yeah.
and then we're now migrating onto the GIMS. Now it is also linked to the final data repository, which we call the DIMS, and that is more for the aggregate data, where they count. For things like maternal mortality, it's still transactional because they are few. Newborn mortality are few. But if you want to get in-depth data in terms of the text and all those things, then we use the transactional data for that. But you have to write. So if, for example, this work that we are doing, we want to even know all the number of patients in terms of the incidence and the prevalence of persons who have been diagnosed with epilepsy or any other neurological disease, we may extract that one from the institution if you are using the transactional data. However, if you want to do the counts and where they are coming from, that aggregate data can be plucked from the DIMS.
And who are the coders?
Who
does the coding?
Who does the coding?
Yeah.
It's inbuilt automatically with the dashboard and everything on there.
Now, I mean, someone needs to determine which code this person encounter will have. You use ICD-10.
Yes, the ICD-10, yeah.
So who is the person that decide, for instance, that this person is a G40 or G99?
So it's also, so within the system, the ministry has a research, statistics, information management directorate responsible. When you come into the Ghana Health Service and all the other, the DIMS data is sitting in CHIM, and CHIM is sitting in policy planning, monitoring, and evaluation, and then it's under the Director General of the Ghana Health Service.
I think I can answer the question as a user of the electronic medical records. So every encounter with an individual, it is the doctor or the physician assistant or whoever is attending to the patient that determines the code. And that is part of the problem because it depends on who is putting in the code and which code they use.
Exactly. So I'm trying, that's a very important thing. And, it might take time to sort that because the coding is key for the findings or what you want to get out in research terms. So one thing that you need to concentrate is to actually start training people for the codes. And that's always a challenge. Yeah, people have different views and that has gone wrong in many places, not only in sort of LAMIC, but also in countries. In China, they have taken this, they're creating a national database, and which will do all the sort of things. And their pilot it has 1,300 hospitals. And they're also incorporating the private sector. And that is a challenge because they, as you said, they're interested in research, but they did something clever. They said, we don't care what system you use, but you need to download this and this and this, which is so each one has an interface according to what they use, so they can download into the main system. Because, it is a little bit, if you are out there, sometimes private sector might have even a better system, but you don't want to miss that. So what you need is to have a minimum set or a set that you can easily export. And that is usually much more palatable to the private sector, if you do that. But, you will have to make it mandatory at the beginning. But after a while, it becomes part of the ecosystem.
Okay. Thank you very much. Okay, Charles.
I just ask if the database is linked to other databases, for example, the pharmaceutical prescriptions or disability grants or anything like that, so that you can have some sort of almost external validation.
Charles, that's a very difficult question. But it depends, yes.
We do have drug data also in the DIMS in the form of drug availability. So it's an aggregated data. However, if you want to go into specific drugs, then you will have to use the LEMS, the new LEMS that we have. But I know efforts are strongly being made to integrate the two. So with time, though you will have the aggregated data, you will also have the individual data if you want in the games.
So as moderator, I think it's an important, so the data is key. Data is, okay, I didn't speak before.
Thank you very much. And I mean, it sounds, quite exciting, really, the opportunity that's there. But all of the points that Lei raised are very well taken, and about who can access the data, how you can access the data, how do the databases talk to each other. But all data is dependent eventually on the person who's entering the data. And what I was really going to ask is, what's the depth of the data? So, for example, if a person has epilepsy, let's say, will the coding just capture epilepsy? Or if they have epilepsy and depression, and there are cognitive difficulties, and they've had fractures as a result of the epilepsy, are all of those individually entered? And how deep does the data go for a given individual? Thanks.
I must say that, yes, in as much as we're talking about the coding, first, it depends on the diagnosis. So the competency of the clinician seeing the patient is foundational. I mean, if you're able to make the diagnosis, then that becomes the beginning of ultimately what you're going to capture into it. So one person can have multiple diagnoses of different things, and that is the depth to which, for the transactional data, that is the depth to which it is captured in the system, yeah. Especially the GIMS, the new Health Information Management System, is still under development. And the director for the director for IT, yes, is working on the new inputs that are coming. And I would say that even though facilities have started using, we are still making it well. And connecting it to the question from the other side, every health data is captured, including the finances, whether it's insurance, non-insurance, equipment that are there, functional, non-functional, how frequently these equipments are being used, the reagents for laboratory comes in, and then how it is being utilized. The new games has everything, very, very comprehensive, including transport vehicles that facilities own and which ones are functional, non-functional, ambulances, the connection and everything. So with the new games, that is what is currently doing. But the details is that it captures everything that is there. If, for example, a patient with epilepsy, ultimately, as you rightly mentioned, maybe falling with a fracture and now has malaria, all these things will be captured. Yeah.
Please, what are the timelines for the new games to be on board?
The games have started. It's been rolled out already. So we are rolling facilities onto it and when. But it's already started.
Okay.
Yes.
It's not fully the teaching hospitals for now.
Yes. Okay. But they've started rolling it out. I think the LIMS started from teaching hospitals, regional hospitals coming down. But this time around, facilities that are ready, we're rolling out, yeah.
Yes, I was going to add to what Dr. Siedu said. So we have a client, but like every month, it's the morbidity the clinician has or the disease condition that the clinician is treating the client for. So in January, we capture this data. I mean, it's daily and it's aggregated at the end of the month. We enter into the team. So if the patient comes today and is treated, it's an epileptic patient, but it's being treated with malaria, didn't report to the OPD because of epilepsy, that data for the month will capture malaria for him or her instead of epilepsy. Yes, especially if it's a refill, a patient that is just coming for a refill. Yes, so that's how it goes. Thank you.
I think this comment has gone to my next question. So what opportunities do we have to strengthen data and monitoring system for epilepsy? We know that under GHS, epilepsy is now under NCD. It's a big umbrella. There's breast cancer, there's prostate cancer, there's hypertension, there's diabetes. So epilepsy is squeezed to the corner. Really, what can we do? That's why we are here. IGAP, epilepsy monitoring. What can we do to change the system to make it more accessible? Because before, you're going to use a needle or a toothpick to get epilepsy data out. What can we do to bring it to the forefront? Tina.
So not an answer to your question, but an addition to it. To bring the conversation, as you very rightly have done, back to what we are sitting here for. When the WHO came up with the IGAP, the Intersectoral Global Action Plan, all our countries, and we're in Ghana, Ghana included, confirmed and signed up to it. So now it is the prerogative of that government, the Ministry of Health, to make sure that there is a specific part of your functioning and your agencies whose role is to maintain the IGAP. So there should be someone not just counting all the data. That's important. You have to count. That's part of the responsibility. But there should be a focus on epilepsy and other neurological disorders and teasing out that data. The rest is up to us. We do the education so that you can get the data, but collecting the data and utilizing the data. So we make sure that the data is adequate and reflects reality, and you are counting the numbers and basing your policy on it. So I think for most of the African countries, but for us as well, yeah, it's not enough that we signed up to the IGAP because it was a popular thing to do at the time. Now we are to be held accountable for why we signed up and what we signed up for. And that is all our responsibilities. The Ministry of Health cannot be waiting for us to give you the data. Yeah, you are part of the making sure that the data is adequate, making sure that the facilities under your purview have the tools to be able to input that data, and then we all collect it, make sure it's all right, and then utilize it in terms of policy.
Yes, Dr. Sid.
So yes, I think she's right. I would say that firstly, it's a collective responsibility for all of us. The problems or the challenges are numerous. As and when new ideas are coming, we begin to focus on some of them, and then we prioritize and work towards it. I would say that many years ago, in fact, yesterday in our group, it became evident that there were two graduate students who said, I mean, this is the first time I'm even hearing about epilepsy. And, and for me, it was interesting. It means that all the work we have done in the past is not waste. It is part of adding on to it, to the fact that it could have been worse. Where we are now is all the effort that we've been able to put to bring us to this point. If you look at the system of profound knowledge in quality improvement, the psychology of human behavior is the most difficult thing. For other things, variation system approach that you see, they are not as difficult as the psychology of human behavior. But I would say that these come with time and exposure. Such conversations we are having today, for example, I'm sitting in this conversation. When I go back, I have a couple of my colleagues who are here. The head of bilateral is here. Quality manager for the Ministry of Health is here. Policy, So we are here. We are also hearing. Going back in our reports, we're also going to make some recommendations. And I keep saying that the more we talk about it, the more it gains what we are supposed to do something. Yesterday, we again mentioned in our group, for example, the way we finance health in this country. We've been doing currently we are doing the free primary healthcare. So a lot of the issues around promoting and things that possibly, to prevent diseases are going to be in the free primary healthcare level. Screening and all that will be there. Now the National Health Insurance kicks in, and then ultimately the Ghana Medical Trust Fund. It is looking at chronic non-communicable disease. At the moment, the focus was more related to cancers and other devastating chronics like kidney disease and things like that. But this is also another important area. First, if the president or policy person makes a pronouncement, it behooves on the implementers or the technical people on the ground how we can start this. I recall that when the Ghana Medical Trust Fund initially, the pronouncement was made by the president, it was supposed to be focused more on treatment. Then as we started working on it, somebody said, but if you are going to treat, how do you make a diagnosis? A lot of infrastructure and diagnostics are coming into it. Then it came up that, but how will you make the diagnosis even if you have the equipment? You have to build capacity in terms of human resource. So now that's transcended right from just treatment, coming down to even identifying people who have an interest in some subspecialty areas to build their capacity, whether in country or external. So it's moving. If we are going to prioritize epilepsy and other neurological diseases, it is us who determine what must go into it because it's chronic, it's a bit more expensive. We discussed not all the new medications are on the National Health Insurance. I don't know whether National Health Insurance is here. You were from? Yes, thank you very much. So yesterday, we realized that if you are thinking about what needs to be, what medication needs to, yes, NHI must be here. And again, with the knowledge and the new information that we are getting, that is how we can begin to put some new things onto it. Luckily, every year they revise the tariffs, and then what the law mandates them to do is about advocacy. So we all need to work together to make sure that this. But I can assure you that NHI is here. I'm here. A lot of the ministry people are, those of us who are also managing the institution at different levels, we are all here. We are hearing. We are seeing what is important. And we are knowing that persons who have epilepsy are not supposed to be left behind. Because the UHC says that even though money should not be a barrier, nobody should be left behind. But we roll people onto it as and when we get better education, we understand what conditions are, can reduce the stigma, improve the way we provide the services, and then they can also get the same quality of care and live the same way that any other person without some of these conditions. So I must say that I congratulate the program organizers in the sense that as we continue to talk about it, we will get. Yesterday, my MC was a bit said in 2012, we spoke about, I said it could have been worse if we didn't talk about it in 2012. So we are talking about it in 2026. It's adding on to all the things that we've done. I must even say, many years ago, I remember in your presentation, there were only maybe a few neurologists in the country, but now we are beginning to have additional ones. So I think it's all the awareness, and also those who teach must also encourage many more people to join. Thank you very much.
So, quick response to that. You're absolutely right. It is all about the number of neurologists, but I want everyone to understand that the actual solution is not in the number of neurologists. Yes, they are important. Yes, we need more. The actual solution is training from the lowest level all the way so that it doesn't matter if you don't see a neurologist, you can still at least get a preliminary diagnosis. Otherwise, what happens is what we are facing now. I'm pretty sure it's the same in the teaching hospital. You get a referral, no diagnosis, something neurological. And they just send no initiation of management, nothing, no workup, nothing. And you're supposed to figure everything out. Then the patient comes, the referral, it was written whenever it was written. They come, the person at the reception station who is going to give them an appointment, gives them an appointment for 3 months or 6 months. So the person is just left with nothing. Nobody's taking care of them because someone looked at it and said, okay, this is not mine, go. That is where we have a problem. So we need to educate all the different levels. You don't need to be a neurologist to recognize a neurological problem. You don't need to be a neurologist to start management of a neurological problem. And that is where we have made a system where the neurologist is this fancy god that makes up diagnoses, and that is not my thing. Let the neurologist figure it out. So we have to change the mindset from medical school, before medical school. The medical officer, the house officer needs to know how to address all the basic things. We're not saying neurologists are not necessary, they're necessary, but they are not indispensable.
Just before you come in, it's as if this has been scripted, but it has not. So the last question here is IGAP implementation in Ghana. So that is what this is. So the IGAP is looking at a lot of neurological conditions, epilepsy, mental health, all put in one, so that at the district, sub-district levels, people can identify that. So going back into time, I think, Charles, was it 2012 when we started SEEDS, we saw the gap. So we used the mental health nurses who were across board, scattered all over the country to collect this data. And those from the mental health authority will bear us out. Instead of psychiatric conditions, we're picking up epilepsy. That was number one. So the training was geared towards that. And over the years, the training has been geared towards this mental health nurses. And then it is tiered up. So I think it's not knowledge. We are about 16, 10 more in training, but it's not enough to cover the country. So we need to look at decentralizing epilepsy care across the level. That's where the IGAP and the WHO.
For research that can be useful for policy. What is the plan of the ministry in integrating that data and making that data available for wide use? Thank you very much.
So I guess you are aware of the... Doc, are you listening? Yes. I guess you are aware of what transpired led to we not having direct access to the data now. But all to ensure that that data is available and it's not completely lost. The data is not lost. The data is there. But we don't have current access to it because of some issues that are around it. So I just want to bring to our attention that that system, they are working around it to get the data back into the system. So that is it. So don't be too worried. It's not lost. It's there. Except that the way it was done, I'm sure when you've listened to the minister, has gone to parliament, how that data was, is where they are still having conversations around how we can retrieve that data. But just to also add that, we have a UHC roadmap. And if you look at creative care, along the spectrum of the life course, it contributes just about 20% of service delivery in this country. So we have promotion of health, which we want to create more awareness. And just to add on to what the doctor was saying, that yes, we are not saying that it's only in the specialized areas that we are talking. We are talking about promoting health for people to become aware that even epilepsy is there and people get it, and that something can be done about it. The second one is also about disease prevention. The third one is where the creative care, when people have a condition that they need to be taken care of. There's also rehabilitation. After people have been diagnosed with conditions such as epilepsy, within the community, people may not be very comfortable. They may be afraid that it may move from them, from person to person and all that. And that comes back into the awareness creation and the promotion. And then people need to be rehabilitated to work. And then ultimately there's palliation. But during all these periods, there are opportunities that emergencies may arise, and ultimately supporting people with their psychology or also the mental health status and all that. So I just want to remind us that generally the health sector goes through that entire spectrum, and we have responsibility to make sure that each part of it is upheld in a way that ultimately we can get the outcomes that we are looking for. So, Doc, I'm not saying that it's only neurology. I'm just trying to make a comparison maybe 20 years ago. And it's not just for epilepsy, but for almost all the cadres. I'm just reminding us that it could have been worse if we were not at this point where we are. And there's more room for improvement. Even when you are first all the time in your report, when it comes, they say more room for improvement. Where are you going to improve to beyond the... Thank you.
Thank you very much. Can I ask the key drivers for IGAP and implementation, especially for epilepsy? I think I'll ask the Professor Helen Cross. She's the president of the International League Against Epilepsy. We are very honored to have her here. Who has the mic? Let me bring my mic down. Okay. So we'll ask Helen to give us some remarks about IGAP implementation across Africa. What you think we can do in Ghana to improve that?
Nothing like being put on the spot. And I'm the immediate past president of the International League. I think what you're discussing, is really important because it is, we talk about implementation of IGAP across Africa, but it is all still country specific. And different countries are at different stages with what is available. We've discussed the access to medicines, the first thing, and I think, the supply chain is really important. Where mapping where the major barriers are, as was discussed, is really important because without an understanding of that, you can't actually make a change at any level. We've talked about data. How is that going to help? I mean, yes, one of the objectives is to have data on individuals with epilepsy and other neurological disorders within each individual country. But how are we going to use that? It's important to know where the patients are, where the gaps are, but how are we going to use that in moving forward? And then that begins to link up with all the objectives. Epilepsy can be utilized as an exemplar in the sense that it is an entry point. And it's not the same in all areas of the world, there's no doubt, because there are different states of healthcare system or different stages of healthcare system. And whereas in some maybe more resource-rich settings, neurological disorders, individual neurological disorders per se, have their own care pathways. But what epilepsy can do is, act as an entry point for defining what services are required, where the gaps are, in order to try and improve access, not only for those with epilepsy, but other neurological disorders, to the care they need. I think you've all discussed things at lots of levels. Tina's talked about training, which is really important to make sure that the condition is recognised and people get point of care. There's the data of who's got it, and then there's the supply chain. So there are different stages, and it all has to be integrated, and this discussion is really moving that forward. Thank you.
Thank you very much, Helen. I know when to tap into a trove of wisdom. Thank you very much for that. So I think we're getting to the end. Since we have the quality manager for the Ministry of Health here, I'll send a mic to him to give us just a few remarks at what you've listened to, what you think we can do as practitioners to improve the quality of the data and the management that we have. Yes.
Thank you very much. My name is Selina Dusi. So I've been following all the discussions, and then I can say that for Ghana Health Service, every month we do data quality validation, which is very, very important to us because sometimes the data they enter into the system is not accurate. So they do data validation. And then we are looking at, as a ministry level, we're looking at how we can harmonize all this data because we want to look into our data. It's mostly the Ghana Health Service data that speaks to Ghana. We have all the GACI facilities, private sector, not all of them are reporting. So what the ministry is moving to do is that, or is doing is that we want everybody to, once you are taking care of patients in Ghana, report into the games, the new games, for us to have Ghana data, not maybe an agency data. And I think the ministry is moving towards having that. We have also empowered the HIFRA. If you are a facility and you want to license or you want to renew your license, how many patients do you see? And how do you think we should license you to practice? So these are all measures the ministry have put in place, and I think my panel members have discussed that. So ministry is keen on having data. Most of the time, things are happening down there, but we only have Ghana Health Service data reporting into the DIMS for us to use. So the ministry is keen in having all people reporting into the data, and the quality management unit is also supporting this force. Yes. Thank you.
Thank you very much. That's a very insightful. So I think we have to have more of these meetings online to get everybody involved. So Arjun has an input into this, and then after that we 1 minute summary for statement by everyone, and then we bring this session to a close. Yes.
Thanks so much, Albert. So I think it's been an extremely useful and informative discussion. And I think that, as has been alluded to, starting the dialogue is sometimes the most difficult step. But having started the dialogue, it's very important that dialogue continues. It sounds like there is a great opportunity to get good data that is always dependent on the quality of the person entering the data and the quality of the data they enter. And that comes back to really engaging people through whatever incentives are necessary to ensure that there is that engagement. One of the things that we highlighted a little bit, but throughout the couple of days, is that treating epilepsy, the treatments are pretty cheap. So actually it's a treatable condition which has vast socioeconomic impact. And so if you can get those cheap medications to the right people in the right way, that can make a difference. And exactly as Helen was saying, that can then give an exemplar condition to open up many, many other care pathways. The two caveats I'd say is there's a slight concern when you mention patients about that if epilepsy happens, but then another condition happens, then that other condition trumps epilepsy. So we've seen that in other places, and that then diminishes the prevalence statistics related to epilepsy. And I think it is true that you can say, well, it could be worse. Lots of things could be worse. What we have to say is it must now be better. Yeah, so I think that we have to take what has been done, take the steps from this meeting, and really use that as a platform to move forward. Because from what's been said in this session and the panel session just before, there's the will. People are ready to do it. People are now sensitized to it. So I think we have a real opportunity. But now it's on the people in this room to capitalize on it. And then, as always, to then take it out of this room and make sure other people get on board with it. Thanks.
Thank you very much, Arjun. I think Charles will have a word in this. Prof. Newton.
I think I just want to really echo what Arjun said, is that, we have a situation where we need to move forward and need to start with simple steps. And it looks, from the sounds of it, it's already started with the rollout of the healthcare system, of the health information system. I guess that the most important thing is beginning to try and work out what the burden of disease. When Emmanuel conducted the preference survey, we provided an estimate, but that's only just one figure, one statistics. What is more important also is the impact it's having on the families and the people in terms of, for example, the comorbidity associated with it, and also the impact it's having on quality of life, which I think is also important. And so that's much more difficult to capture in data and statistics than just some of the simple numbers.
Thank you very much. So in conclusion, I think I just need a little bit of clarification from me from a teaching hospital and the Neurology Society of Ghana perspective. So rolling out the IGAP, yes, WHO wants us to integrate the IGAP into our systems. Is this under the Mental Health Authority? Is it under the Ministry of Health? or can we roll IGAP into the GIMS platform that we have? So just a quick response. I like the way you are looking at me, Doctor. Both GHS and mental health.
Okay, so what I would say is that it's the responsibility of all. But we know that in the Ghana Health Service, mental health authority has a supervisory coordination role, and the Ghana Health Service, as one agency of the Ministry of Health, the largest agency, is able to serve many districts and communities. So I would say that since the MH gap tax shifting sharing, which had capacity building for primary healthcare workers to identify and manage common mental and neurological and substance use condition, it sat under the Ghana Health Service Mental Health Department. I have to also say that even within the Ghana Health Service, we collaborate with the NCD program, which is under the Public Health Division. So we will need further engagement on this, but ultimately we will be collaborating with the Mental Health Authority, the Mental Health Department, the Public Health Division, and NCD program.
Thank you. So just to bring this up, that we've been trying to send this message across throughout, that epilepsy is not a mental health condition. I think everybody, let's say that epilepsy is not a mental health condition. Again, epilepsy is not a mental health condition. So if you don't learn anything at all today as you are going, please say that Ministry of Health, say that Ghana Health Service, say that Mental Health Authority, say it twice so that it sticks in. So that this is where we have a little stickler. So we have to tease it out because she's done the pathway. Yes, you want to correct. Okay.
So when I said the mental health department, it's a small department within the institutional care division, and I should be highlighting the institutional care division also.
It's interesting. There's a maze that we have to get this. So I think it is our responsibility. We have to continue the negotiation to get epilepsy out there so we can go. So those are some of the technical issues that we have. So there are different levels. Traditionally, because of how epilepsy has been managed, still the psychotropic drugs are released under the Mental Health Authority. Some are released under the Ghana Health Service, the MOH. So there are lots of, I won't say duplication, but there are parallel things that do not add together. So this is one of the drawbacks, I think, for the implementation of IGAP in Ghana. So I think with the Ministry of Health, with the WHO, and with the other stakeholders, we'll have to make more inputs into that to have a clear path so we don't have to do steeplechase to get into that. So on that note, I'll let everyone give a 1 minute submission on how we can improve the process.
Thank you. Okay, so for me, the awareness creation and the advocacy must continue because there's a lot of knowledge gap at the household level, community level, and also at the clinical institution level when it comes to epilepsy and its management. So we need to keep the advocacy on. We need to keep educating ourselves from the community health officer, the community health nurse, the physician assistant, the medical prescribers. We must know that now there's a new trend of managing epileptic clients, and this is the way we should go. Thank you.
Thank you. I think we've all said it in lots of different ways and in several times how important education is across all levels, across all different disciplines. I also think that to support the awareness of epilepsy and other neurological disorders, we need to change the narrative from disease to brain health. And then that way we can incorporate all of these things because they often happen together with comorbidities and all other, with all other kinds of disease and states of health into, when we're talking about brain health, we can incorporate it into all the different other services, into the NCDs as well. And make sure that all the other different disciplines, because they have brain health in mind, they are also keyed to notice when your patient with heart disease has a stroke and now has epilepsy on top of it, that kind of thing. So education is key, and then the narrative, the language we use in making our population, our healthcare providers, all the different stakeholders involved in understanding what brain health is and how important it is to maintain brain health and then appropriately manage the lack of health.
So what I will say with regards to data, truly when you look at the national interface of the DIMS, all facilities are captured, including tertiary hospitals. It's just that for some of them, you will not find the data. And it will be great that the regional directors of health services and the district directors of health service are able to aggregate the data from all the facilities under their jurisdiction. What I will also add is the need for collaboration with health information officers for the various focal persons. This collaboration is important so that even at the facility level, there's proper validation of the data before it goes to managers. Thank you.
Thank you. It's been exciting being here. It's my first time. And with all the discussions we've had, I'm very hopeful that we are moving forward. And I also want to stress on the collaborative aspect. Apart from advocacy, in the management, I think we should collaborate more. We're talking of medication. Without medicines, our treatment is not complete. So in collaboration, we should collaborate more with those that manage medication to make sure that we have continuous access. Thank you.
Thank you. So from the ministry, we'll continue to thrive on our framework that we're using, which is the UHC roadmap, and continue to encourage our agencies that are mandated to play their role, right from promoting prevention of diseases, the curative part, rehabilitation, and palliation. We know that in the past, a lot of the diseases that we've been able to prioritize and put in a lot of effort were more, funded externally. Now we know that donor funding is also dwindling. So we are mobilizing more resources. So from our side, what we'll continue to do is that, yes, once we promote epilepsy and other neurological, I like the word that yesterday we've been using, and then today Doctor has also mentioned that we look at brain health. And then once we look at brain health, we'll be able to situate it and all the other facets will come on board. I must say that together with my colleagues who are here, we are going to advocate for brain health to be a bit more prioritized, because at the end of the day, that holds the entire body to move it forward. Thank you very much.
Thank you very much. Please, let's give everyone a big clap. And the theme for the World Federation of Neurology in the next is brain health across the ages. So children, adults, and old persons. So I think we've had a very good, lively discussion. Lots of things have come up: validation of the data, collaboration, more advocacy, brain health, data integration of this data, and then making more noise. And the ministry mentioned something which tickled me. He said funding. And many years ago, we said epilepsy is not flamboyant, so it will not attract the millions and the cars that maternal and child health and others did. So what we tried to do was piggyback onto these activities, and their funding has run out to as well. So I don't know who we are going to piggyback on, but I think brain health across the ages, we have to make noise for our patients living with epilepsy. We need to get more access. We need to put epilepsy in the forefront. So we can only do this by making more noise. So I thank all the EPINA team for bringing us here and getting these discussions ongoing. It's been 2012 to now. I didn't realize that long, 14 years. So Charles is still the same, and Arjun is still the same. Leigh has got a little grayer, and Helen is looking younger. So my gray has come. So I think 14 years down, there are champions here. We have new neurologists, we have new nurses, we have multidisciplinary teams coming up. Let's put the fights on, and we have our patients and our persons living and our carers, and we can't do this alone. We need to do all this together. So thank you very much for listening to us, and panel, thank you very much for being engaging and spewing your hearts out. But remember, epilepsy is not a mental health condition. Thank you very much. So you may go back to your seats now. Okay, we have to take a group photo. Okay. Thank you very much. My notes. You've taken. I made some notes. This one, yes. Okay.
Okay. Lunch is 30 minutes late, so we are going to use the opportunity to do our workshop quickly, and then we get a feedback from the workshop after lunch, and we take other matters. So what we are going to do currently is to go into two groups, as we did yesterday. So we are going to have our panel into the panel who were just here into the two groups. So Dr. Patience Mamata, you'll be in group 1, and then Dr. Ajwaku Sichre, you also be in group 1 as well. Then Dr. Edna, and then Dr. Chawe, you'll be in group 2. So for the rest of the team, we're going to number 1, 2, 1, 2, and then we split into the group as such for the discussions around data monitoring and evaluation system for epilepsy and other neurological conditions. Yeah, so I think we start from 1, yes. 2, Professor John, 2, okay. 1, yes. Okay. Yes, 2. 1. 1, okay. Dr. Asidu Yolene, yes, so 1, this one, so you are 2, and then 1. Yes. Yes. Then let's go on. Let's follow up. Yes. So one, yes. Oh, okay, quickly. Let's do this quickly so that we can. Yes. Okay. So we all have groups now. So group one, you be on my right. Group two, to my left. Group one, your moderator will be Dr. Maureen Mate from the Ministry of Health. And then group two, your moderator will be Madam Sabina Esiama. So group two to my left and group one to my right.
Hear what is going on. We can plug this here, right? Sorry. And then we'll be passing this around as the microphone. Thank you very much. To capture the audio very well.
Can you get one of the young ones to take it around for us? Hey,
Thank you.
this one there is so we have 9 questions to answer, and our objective is to develop. Oh, please, Prof. Ajay is calling me. Let me pick it. Hello, Prof. Okay, so uh, this one here. So our objective is to develop a plan to improve or strengthen data, as well as monitoring of all neurological disorders in Ghana. So we have questions to answer this objective. So, Madam, you are ready. So our first question is, with this objective, uh, what gaps exist? What gaps exist? We won't spend much time on this so that we can, in Ghana. Okay, yes, sir.
In and it's supervising data, improving training, having, for example, depending on the set of for that level of healthcare, but not some abstract, sometimes just write things. Make sure that the person who's entering the data knows what they have to choose.
So you said the person entering the you mean
Thank you. It's a microphone just for the people.
Yeah.
Okay. So I entirely agree. I think even more than that, though, there has to be engagement of those people to enter the data in the first place. Because unless there's some engagement for them to want to do it, then it doesn't matter at all. No one will do it. So there has to be metrics around the quality of the data, but the first step might be to ensure that everyone wants to do it. And patients can drive that as well, and carers can drive that and say, well, look, you know, I really want that. I want you to enter my data. I want better care. So there can be some patient-driven drive to that, but there has to be engagement around the data.
okay? Patient.
Yeah.
Some record keeping.
Disincentive and people aren't keen to enter codes and things like that. But I also think that if you start it, then people start to get more and more.
So I think it's more important to add it to the routines.
Yeah.
If you know this is all other diseases when they can be recorded, why not neurological disorders? So it should be part of our routine work. Okay.
So I think the orientation of providers, as in whether it's the prescribers, because from where I see, there have been a number of specialists in dementia and some other neurological conditions. You go back and find you still refer them this the mental health I think we need to start from the providers also understand why they are still reluctant or feel incapacitated, why they will not use the knowledge to provide service for people with epilepsy and other neurological conditions. And I'm happy when it's not a mental condition. It's condition that should be managed like we manage malaria, diabetes, etc. So that we create the level of access that's really to ensure that people.
Okay. Thank you very much. So we will move on to our second question. And needed to address these challenges. Okay. Okay. So we mentioned a lot. Adding it to the routine is also one thing to do. So we'll move on to the third then. What are the roadblocks to this action? And
No, I think we're supposed to record. So I'm supposed to have that other microphone.
they're taking it away, right?
Oh, okay. So main obstacles of view is education and then incentivization. It's one thing, as mentioned, you've trained everyone, but they're not doing what they've been trained to do. So it's to make sure, incentivize, make it part of the routine, which it technically already should be, and then monitoring to make sure that what is supposed to be done is what is done. So education, training, control,
Okay.
supervision.
Monitoring is key.
Yeah.
And I will add evaluation. I'll add evaluation. So monitoring is key. Any other thing?
Yeah, I think we mentioned it during the panel discussion, making sure that private facilities and other other non-Ghana Health Service facilities are all onboarded onto the DIMS and are being forced, for lack of a better word, being forced to enter those data into the DIMS. That would be very helpful because if they are treating and they are not reporting, you don't have a very good picture.
Okay.
I think a nicer way to put it is not forced, mandated, which is the same as forced. But absolutely right. You can't be part of a system, and it's not as if a private healthcare facility is autonomous all by itself. We are all still doing the same work. So the data collection has to be part of what they do. So in order to get a license, as was mentioned by the rep from the Ministry of Health, yeah, you can't have a license to practice medicine if you don't know that that is part of the practice of medicine and its data collection. Those are integral parts of the practice of medicine, and we need to make sure that it is upheld.
We move on to the next one. Oh, is that okay? Doc.
I think we need to have leadership prioritize epilepsy and other neurological conditions. When you look at the other conditions, the facilities are expected to report on it. There are indicators to assess facilities, the number of malaria cases you are seeing, the number of pregnant women getting their anti-malarials. There's something to. And so when we at least use epilepsy as a trace, as a condition to say that how many people within your catchment area that are expected to have the condition have you been able to reach out in terms of providing service? We will look out for them.
Okay.
I believe there's limited funding from the government to study some of these neuro conditions. So to add up to what she said, limited funding from government to support or research into some of these conditions.
Okay. I agree with the limited funding, but I think that is part of the problem we have had historically. Again, back to the practice of medicine. It is an integral part of, and yes, it needs funding. But to say that I need extra, my incentive to do what I'm supposed to, yes, it would be an integral part of what we have all committed to. That the mental health committed to, yes, it needs funding. But we can't tie the two together and tell people that no, you shouldn't do it because there's no funding. You should do it because that's the job you agreed to do.
To be paid.
And then it's the Ministry of Health, it's the Ministry's responsibility to ensure that it is easy for us to do our jobs, not necessarily more difficult. I think part of it is an ethical question.
So, yes, I agree. And there is a moral and ethical dimension to it, but you can incentivize in other ways. So you can say, for example, if you show actually the burden of epilepsy is very high or the burden of neurological illness is high, you can then reprioritize and get more neurologists and get more epilepsy specialists. Not that you in any personal way benefit, other than you create a better ecosystem through showing how important these conditions are. So there are other ways to incentivize beyond purely financial incentives.
Exactly. Okay, so I think we've spoken a lot on that. Let's move to the next one, which we have answered anyway. Who are the stakeholders that will take these actions? So all the people that have been mentioned, the doctor, the nurse, the patient themselves. Okay. So who are the contributing stakeholders to these actions? The same. Those are the same supporters. Is that Ghana Health Service? To help. Any other contribution? Okay, so we are okay with that. What resources are needed?
Internet technology to support that internet. So there's no use sitting behind a computer that cannot just load the document you need to document. And so there has to be ready access and then the technology to support it. So even that's
Computers, even the computers, not all the facilities. Not all the facilities have the computers. So training.
Back to training.
Training. What else? Data infrastructure. When what goes into that? Okay. So at what level? Higher level. Okay. Okay.
That's the challenge they're going to face. They have this giant system that's supposed to cover all the public sector, but I don't know that they've put provisions in place for the servers that are going to carry that data system. And as soon as the server starts to not be able to handle the amount of information it gets, everything's going to collapse.
Yeah. So the servers will be needed only at the top. What about across board? Yeah. Okay. Because at the small facilities, if they don't have the servers and something happens, the data there is gone. Because they are going to take it to the higher level where all people are bringing their data so that they put it together. So if at their level, they can't save it.
Yeah, that's definitely right that you need it across the board, but you also need IT support. So actually, if the computer fails in the district facility, then someone can help actually fix it and get it up and running again, because otherwise you'll lose data entry for as long as the computer is unavailable, especially if it's the only device.
Okay. So the training is also important. So where the IT support is lacking, those has knowledge. So the training is equally important here. Okay. What is the timeline for this action? Timelines. What will be the timeline?
That depends on the availability of the infrastructure. So technically, it's already ongoing. It needs to be built up. Can't take too long.
The answer. So what are the timelines? Because I know there are times that you need to submit. They have their timeliness and completeness of data. I know way back when I was doing health information system, you have timeliness and completeness. And the timeliness is that there's a deadline. They're giving you a date that it should be submitted. And the completeness is everything that needs to be there is there. So if they are looking at completeness, then neurological disorders must be there. So if the data comes and it doesn't include it, then it's not complete. If they keep timelines of completeness, they are ensuring that it is there, then it will go on time and it will be part of it. But if it is added as a routine something, then it will not go. So it should be routine so that when they are marking completeness, they should ensure that it is also there. Okay, so the timeline goes according to when the routine data is going. Okay, so question 8. Okay, if you have anything to
Not specific timelines. I think that usually, if you are looking at timelines, maybe you have to have the data governance and then validation protocols in place
Wow.
before you can put specific timelines to. I think so. Maybe for that, that's what I was. But as far as a plan is concerned, once the plan is in place, it can be synchronized with what other reporting timelines has been there. Then we know how do you then fix when to report on this and when not to report and when to finish it. That is what I can say.
Okay, any more? There's a hand up.
In terms of timelines, I'm looking at this differently. I'm looking at it not in terms of when the software closes and when to enter. I'm looking at the timeline for the assignment we were given, which is to come up with a plan of closing the gaps. What were the gaps we identified? Training, the unwillingness of clinicians to be specific. So what sorry. What were the solutions? And what are the timelines for those solutions? And not necessarily when to enter the data. How to get the data. What are we doing to get the data? For now, we are not getting the data because people don't feel trained enough to come to specific diagnosis. I think we enumerated a number of them. So what are the solutions to those issues? We also mentioned it. The timelines I see here are when are we solving those problems and not necessarily entry of data.
In general.
Yes.
According to what we have done.
Yes. So what is the plan? The objective we have.
Okay, is to improve or strengthen data and then monitoring all neurological disorders.
And we identify some gaps, right? And we came up with proposed solutions for that. So what are the timelines for those solutions?
Okay.
Do you get me? That's how I see it.
Do you get her? So what are the timelines if we are going according to the objectives that we are working on?
Timelines or you want us to
Timelines that we can stick to.
Exactly. And that is why it's difficult to state any timelines here because we can't sit here and commit the time because it goes beyond just here. So, I don't think we will be able to fix timelines with what we discussed here, unless maybe I'm saying it
Differently, like I was seeing it differently.
I think you're right. It's going to be very difficult to create timelines and say this is definitely what it's going to be. But we could
Are you taking notes? You
relatively
go and present it.
aspirational
You
rough
go and
idea
present.
timeline. So it might
Do
be
it as you
say
can.
6 months to do the engagement work, so that everyone knows that the new system is available and how to enter the data entry onto the new system. Another 6 months to make sure that the computer infrastructure is in place, and then 18 months from now, we expect 90% of people, 90% of people will be entering data correctly. Something of that order, yeah?
Okay. Did you hear what he said? Okay. Okay, so that's our timeline. What will success look? How will it be measured? How would we know we have arrived? What will success look like?
We spoke about it, and she raised a very important. I think one of the issues that was discussed was the treatment gap. Maybe we'll know when we are there if we begin to, if we are able to reduce the treatment gap. That could be one, and maybe access to
Like you said yesterday.
access. So these are the things that if we to know whether we are there or not.
Okay.
So that's just one.
Okay. Any more? No, Doc.
I haven't been here and I don't know what you discussed, but I want to share something around what success will look like.
Yeah.
That many more people in this country are aware, because I'm looking at it as creating more awareness right from the basic school. I just had some conversations here with someone who was interviewing me and said that when he was in school around the JHS, they had one lady who had, and everybody was afraid.
Mm.
So the first thing, what success would look like for me in terms of awareness creation, that many more people know that there's a condition called epilepsy. It exists. It affects human beings like any other disease, and there's an opportunity for it to treat it. That is one, because
Okay.
some of them you might not be able to prevent. Two, that people are not necessarily born with it, because anything can happen. For example, if you are involved in trauma, head injury,
Mm.
you may end up having seizures.
Mm.
If you even get meningitis, you may end up having seizures. So it is one of usual disease that can affect anybody. But treatment is also available.
Okay.
And now from our side, yesterday, based on the conversation, success will again look like availability of medications, the different kinds of medications that will be readily available to patients to use, and that because we don't want financing to be a barrier to care, people can have access to it because maybe the National Health Insurance will cover it, or any other financing mechanism like the Ghana Medical Trust Fund is available, so that people can have access. Just like if you take malaria, medications are readily available and we can have access to it. And the third one, again, as part of the awareness creation, people can readily be accepted and be reintegrated in the system.
Yeah.
Not people seeing a person with epilepsy and thinking that they have limited opportunities in life. Somebody is going to employ and is afraid that if you employ somebody with epilepsy, it may reduce your what? Yes, your man hours, because you may have to go to the hospital. Secondly, it may reduce your how people view your organization. If
Once they realize someone
so
is having epilepsy, they will stop coming.
exactly, somebody's a receptionist,
Mm.
and because the person has been diagnosed with epilepsy, he cannot find a job, because if you sit there and maybe you get a seizure,
People will not
people
come.
may exactly, so preventing people from having, so that kind of reintegration. And then finally, how I want to see success is that persons who have to take care of, or carers of people with epilepsy, will have a certain system in place where that flexibility, for employers and things like that will be there, and that you can take some time off and continue and then come back, and without losing a job, so that you can still maintain your livelihood as a person.
Okay.
Thank you very much.
Okay.
Just to add to it, success will look like this for me, where we find a child in a school having epilepsy, and then the parents of other children will tell the headmistress, if you don't send that child out of the school, we'll take our children. So looking at 1 to 10 ratio, you prefer to send the child out, so you maintain this other people. So where everybody get to understand, even the children themselves get to understand that our colleague, this is his condition. And success will look like this for me when someone have a seizure in town, and you can always have people who want to come and do the recovery or take her to the recovery process, him or her through the recovery process, and then everyone is fine. So nobody is afraid of that word epilepsy. That will
Okay.
look a great success for us.
Okay. Another success for me will be people knowing the cause. Because yesterday we heard the man, he had it when he was 33. He's over 50 now. He didn't know the cause. And I was interviewing a mother, and the child, they are relating the cause to spiritual things. But in our conversation, so when was the first time you saw your child having seizure? And she said, I was telling you yesterday, the child was playing with a colleague when the child was 13 years when I was interviewing her. When the child was 6, someone her age, they were fighting in a house, a compound house. And a sibling of the one that the child was fighting picked a stool and hit the child's head. And the child had seizure. And from then it has continued. But she's contributing it, relating it to curse and spiritual things. But that was where it started from. So people knowing the cause is success.
I was actually going to say success means we are not attributing to spiritual causes.
Yeah.
I believe those are excellent points you all raised. But how is data going to speak to these things that we have mentioned? How are we going to measure it? Are we measuring it in terms of number of advocacy that we have done to say that, okay, in this year we did this number? How is data to all these things that we have mentioned?
So you want to answer?
Yeah, my comment was very similar. So all those indeed are excellent points, but not for the topic we have at hand. For the topic we have at hand, it's data and monitoring. And the measurable for data and monitoring is not education and the education gap. It may be the access gap, a narrowing of the access gap, seeing how many people are accessing, and then the data itself is the measurable as well.
So
Yeah, I'd very much agree with what's just been mentioned on the front row. For this specific session, we should really think about what success looks like for the data flow. So that might be that every rural clinic has an up-to-date computer and server with reliable internet connection, that every clinician is aware of the new electronic medical record, that 90% of people are entering data in a timely and correct fashion up to that record, that percent of records checked. That kind of thing is probably where I would push your success to look like for here, and then I would bolt on all of the things that have been mentioned as the overall success for the epilepsy program.
So now that we don't know, we don't have much data on epilepsy and other neurological disorders. If, for instance, from now onwards, we start seeing a lot of cases, is that success? Because we don't have the data. They are there, they are not reporting. So they are in the communities, they are not reporting. And now all of a sudden, education has gone on, which is linking to data. So people are now seeking for help. And so our data, we are getting higher numbers reported. It's success.
Yes.
Where other cases like malaria, when you see a lot of cases, it's not a success because you want it to drop. But this one, 3 cases, success. That's how I'm thinking.
Yes. So I want to say that when the perceived numbers of people living with epilepsy is compared to the data that we have collected, when they are aligned, because we know that the cases are there, we hear of them, but then when the data comes, when the report comes, the numbers are not reflected. So when that gap is narrowed between what we perceive and then what the actual data says, then we know that we are closing that gap.
Okay.
Do you want to go?
So success will mean we are closing our treatment gap, and it will be evident by maybe our next IGAP survey where we are able to show the actuals, or at least the near actuals in terms of numbers that will show improve access and etc.
Okay.
Yeah, I think that's right. You know, closing diagnostic gap, treatment gap, education gap, and then adherence gap as well is going to be critical. And you have the baseline statistic. I mean, epilepsy has a prevalence roughly 1.5%. So if you're getting that kind of reporting, then you'll know that you're there or thereabouts.
Okay. Alan, we have 5 minutes, and we left with one. We are left with one question, and that's the last part of the objective, which is about monitoring. So how will success be followed up and monitored, or progress be followed up and monitored? How will we do a monitoring of what we have done?
So I think it will be looking at the data, making sure that the data remains within the expected
levels that we are doing. There's not a sudden drop or sudden this 20% instead of the 1.5% that you are expecting. And then I think it is retraining, reconfirming qualifications. Yeah, to make sure that the person who is continuing to collect the data still knows how to collect the data, or if there are new people coming on board, that they are also trained to collect the data.
Okay. Thank you. Okay. No. When it's finished, you give it to. Oh.
So yes, for following data and measuring it, maybe we just would need to have a resource framework that we would have to track, and also, and this normally will be a routine data collection from all points, and then the other one will be through surveys to be able to determine what is happening after we have made interventions. I think basically that's what you do normally if you want to know how to collect, if you want to collect your data. So that's what I would say.
Okay, thank you.
And I think that both of those are extremely valid. And then the other thing you could add is that the standard operating procedures are updated in a timely manner. So, that you can track, when was the SOP actually updated? So if you have version control and dating of that, and as the infrastructure improves, then the SOPs will improve as well, or will adjust.
Okay. Yeah, that's true. Thank you. Now we are done with our questions, but we are still here. We've not closed. So if you want to add anything to any of the questions, maybe you've remembered something that you think would be important for any of the questions, we can contribute or add to it before they ask us to stop. Hey, my ladies, you want to say something? It's a learning process, eh?
Yes.
Okay.
Thank you very much. So I believe one of the main purposes for having events or gatherings like this is to create more awareness. And so I'm looking forward to perhaps the next meeting having more young people in the room, especially the students or people who are currently in medical school, the pharmacy school, and then those in the health sciences. I have a legal background, but I've been very interested in health or public health generally. So I volunteer with the Ghana Malaria Youth Corps, and we are currently here for a training with the United Nations Populations Fund. And those of us who were interested decided to participate in the conference. So I'm just hoping and looking forward to having more young people, because there are so many of them who would be surprised by the kind of information. For instance, when I saw epilepsy, I mean, I've heard about it. So the first time I had a personal encounter with epilepsy was when one of my classmates from my undergrad here passed, and then I heard he had a seizure, and they said he was living with epilepsy, and I was surprised because throughout our 4 years in school I never saw him have that kind of encounter. So I think we need more awareness, and then we can do that through the young people as well. Thank you.
Very. I like it. Yeah. So we have to do that. So I'm happy you've heard it. You've heard all that we are saying. So also take it to your colleagues and others at home that this is it. So that's the education.
This is the kind of attitude we need. Because you see, the people of your class, they don't even want to hear it. And then when you mention it, then they begin to remember what their grandmother told them. And that is why they see people have seizures and they don't want to go close to them to help them. So this mindset, in fact, your kind of personality is very important to this project. So you need to make more of your type. Yes. That is why yesterday I was saying that, you see, tomorrow if I go home and I don't wake up again, does it mean that advocacy should die? I was super excited when I met Mr. and Mrs. Ajimai, because even my vice doesn't want to talk about epilepsy, but she is a person living with epilepsy. She doesn't want to come out and show you as Dr. Pali with Prof. He will tell you, we've done everything we can. She doesn't want to come out and talk about the fact that she has it. But she has a condition. And she supposedly to be one of those that are going to champion this cause. Me, I don't have. I had the opportunity to live with someone who has it. And I'm passionate about doing it. But the one that is carrying I don't want to use the word burden, but for lack of a better word, is not interested. So that is one challenge, that is one huge thing we've been praying for. So if you have this mindset, then you can help those your friends for them to understand the right information. Then I bet you we'll have
Okay.
more champions.
Thank you, thank you, thank you, everyone. Great contributions. Thank you, thank you.
Announcements, please. You should be nominating the person to speak right after lunch. We would go into the plenary session right after lunch. So you have an hour for lunch. It's 2:15. So please, you go for lunch now and come back at 3:15, and then we have our discussion and we close. So thank you very much for your time. But we have to go for lunch. Thank you.
She'll be here, she'll be here. Don't take away our points. Please don't go, okay?
from the group of us? Group 1. Okay. Thank you, Doc.
Good afternoon once again. So I'm representing Group 1. So for Group 1, we discussed the gaps that exist. And from our discussion, it was quality of data collected at the facility level, which needs to be improved. Example, the ICD-10 codes and also the translation into games and DEMS. The second gap was about integration of data collected from all facilities. So to have a full integrated system where we can access disaggregated data from facility level to teaching hospitals. Another gap was the intermittent internet connectivity challenge at the primary healthcare level and inadequate data capture, which does not include the traditional and faith-based healers. So we know that these are alternate providers. In our setting, they are often the first point of call for patients with epilepsy and other neurological conditions. So not being able to capture data from this group was also noted as a challenge. And then a challenge with limited resources in some facilities. So some of the resources that were stated include computers, laptops for data entry. And then there was lack of awareness on epilepsy as a treatable condition, leading to underreporting of cases. So after identifying the gaps that exist, we looked at what actions are needed to address the challenges in the short and long term. So we thought about capacity building for those collecting data at all levels, as this informs policy, advocacy, which is needed, consistent advocacy to be able to support resources. And an example was given about some districts not having internet service. So need for advocacy to have the internet service, the Ghana Health Service internet service installed in those districts. And then advocacy for other resources that are needed. Another action was the Ministry of Health to engage with the body that regulates the traditional and faith-based organization so that we can have an integrated system including them and include their data also into the DIMS. There was also need for the health system, healthcare workers and the system. So, for example, districts building a relationship with these traditional and faith-based organizations so that that collaboration could lead to them referring patients to facilities for treatment. And then also having an integrated system where all actors are part of the data training. There was also need to develop specific indicators which can be monitored on the current information system on brain health, and increase awareness on activities to increase uptake of care at the health facilities. For the roadblocks and how they can be resolved, we thought of limited funds for most of the activities, which includes capacity building at all levels, and then also the potential for tensions between traditional and faith-based organization and the general healthcare system, which can be ensured by continuous engagement with these organizations. Of course, there was also a risk that these organizations may not comply with the legal frameworks. So for the stakeholders that can take these actions up and who to lead and initiate, we thought of the Ministry of Health, the Ghana Health Service across all levels, and teaching hospitals, NHIA, HEFRA, CHAG, the private health sector, professional associations, Traditional Medicines Council, academia, research institutions to identify the research gaps, development partners and donors who provide technical and financial support, and also telcos who have a role to play when it comes to the internet connectivity. The resources needed are financial, capacity building, human resources, logistics, such as computers, having servers, and registers. Registers for periods when there's a challenge with the network or connectivity. For the timeline, we thought that the initiation of engagement could start immediately with stakeholders involved, also with the traditional and faith-based organization. So that should be done across all the different levels by mid-year. Also, we can initiate the advocacy for logistical and financial support to be able to achieve the actions that require these resources. What will success look like and how will it be measured? So for us, success will look like a good quality, well-captured data, all facilities reporting into the DIMS, which will be measured by the rate of reporting, all interventions being evidence-based on available data, having performance indicators for brain health, access to care for all individuals with epilepsy and other neurological conditions measured by increased case reporting, then improved perception of people with epilepsy and reduced stigma, which will also be measured by increased uptake of care. How will progress be followed up and monitored? So this will be done by the rate of reporting by health facilities and rate of case reporting nationally. Also by the rate of uptake of care. Thank you very much.
Thank you, Group 1, for your presentation and your feedback. Since the two groups look at the same issues, we then will call on Group 2 to also give their feedback, and then we can have a general discussion around it. So, Group 2. Yes.
All right. Good afternoon. Thank you for the opportunity. And I'm Togbenu Ezekiel, representing Group 2. And we look with also with the what gaps exist. We look at data, how we capture data, and then we talk about the supervision and data collection. We also look at the metrics around the data, and then we will also talk about the routine of the data being captured. We also look at how to build capacity to ensure that data are captured well. So these are the few we've captured. And then what actions are needed to address the challenges, urgent or at long term, So now we look at ensuring that data collected are put into DIMS or into information system that is needed. So we also talk about ensuring that routine data, we also talk about routine data that are collected are part of what routine data that are captured are part of what is entered into DIMS. Yes. So we look at what the roadblocks and how they can be resolved. And we talk about incentive to ensure that data is collected. And then we talk of education. We also talk about monitoring and supervision. So these are things that we can do. These are some of the roadblocks. And then at the same time, there are things we can do. Be able to educating the public to understand the condition, and then to come out to speak about it, and then to seek for care. And then the stakeholders or those who are trying to get the data being given the incentive needed so that they can bring the data which is needed. And ensuring that supervision, that is maybe the district level, ensuring that those are the sub-district level are doing what is necessary. Those are the region, ensuring that those are the district are doing what is necessary, as well as national, ensuring that region is doing what is necessary. Then you look at who are the stakeholders that will take the decision, that will take the action. And we talk about the Ghana Health Service, the Ministry of Health, the uh, those who need the service, that's the clients, and then we those who render the service to them. We are all stakeholders, and then community leaders, we are all stakeholders. So we all have to play a part, or we all have to lead in ensuring that this gap is bridged. Then what resources are needed? Resources needed, we talk about technology, then human resource, that's training, organizing training to ensure that people are well equipped to collect this data. And then providing data centers, and then infrastructure to ensure that data is well preserved and taken. Then we look at what is the timeline for these actions, and we were like, from the time we identify the gap, and then planning our objective, that's the time for you to begin to do something or to collect your data. We should also look at completeness, or timelessness, and then completeness. So from the time, as I said earlier, from the time you get your objectives, and then action put in place, and then to the time of you collecting, ensuring that what you want to achieve is done. That is the time period. Then what will success look like, and how will it be measured? So what will success look like, and how it will be measured? So we said that where anyone who need a service is able to access it, and where people can be accepted and reintegrated into the system. And we also look at where there is less stigma, or stigma is absent. Yes. Okay, so these are the few we've captured, and then we also say that when the data reflects what we perceive already. So if at the end of the day what we perceive we have to achieve, our data that we have captured is reflecting on that, it means we've made progress. And then when we meet at our next meeting, that's where we can also measure our success. And we also look at how will progress be followed up and monitored. And we looking at the data and making sure that they are correct, and then training and retraining of data officers so that they can enter data correctly. And then And then result framework can be tracked and checked. Then standard procedures are updated to ensure improvement in data. So these are the few we also captured. Thank you.
Thank you all very much. And thank you, the moderators, for the sessions. All too soon, we have come to the end of the session for today. And we are very much grateful for all your contributions and your time that you have spent with us. Please, for those who put the notes together, we would be grateful if you could share it with us. Please do share it with us so that we could put it together as part of our reporting works that we have to do. Before we finally move to the next one, there are some people we would want to honor and thank for everything that they've contributed throughout the project. And so, whilst we wait, Ima, could you tell the team to bring the things, please, in? They've been very instrumental in all of this, the project, the dissemination, everything that you see that has come together today, it's because of these individuals. And as we say in Ghana, we would like to thank them and also appreciate their efforts and let them know that they are part of one big family, and we always would cherish them as we move on in our various endeavors. So please, I would like the ladies to come. Sabina, Isabella, please come. And Emmanuel, please come. Sabina, Isabella, and Emmanuel, please come and do us the honors and do the presentations also for us. Okay. So first on the list to appreciate is our very own Professor Le Sanda. Professor Sanda, we would be grateful if you could come forward a little bit for us. Please. Professor Sanda, the University of Ghana team and the EPINA team would like to thank you very much for all your efforts in helping our students and the project and all of that. So she's going to actually dress you like a native. Oh, please, everybody wants to see it. They would wish you come up here. Thank you. Oh, no, it's fine. It's fine. So Sabina will do that for us. Thank you. This is beautiful. So, do they take the picture? Yes. Put Isabella, the pictures, please. You take the pictures with them. Isabella, take the pictures, please. Yes. Thank you very much, Professor Sanda. We are most grateful for your efforts towards all of these. Thank you. Thank you very much. You're welcome. Yes. So next on the list is Professor Helen Cross. Professor Helen Cross. Please, a round of applause for Professor Helen Cross. Prof, so what they are going to present to you, it is a beautifully woven kente, right? It's actually a very nice cloth that they would have to decorate you with it and show you how they decorate it. Yes. So Professor Cross, please, could you come up stage, please? Thank you very much. And she's going to decorate you with it to see how it's done. So many things. You could sew it, you could use it for presentations and much and all that. Thank you very much. This is beautiful. Professor Cross, thank you very much. Thank you. Thank you. You're welcome. Thank you. So the next is Professor Arjun Sen. Please, a round of applause for him. Professor Arjun Sen. Prof has been with us for a very long time. He loves to show Ghana. One thing I love about him is that he loves to show Ghana. What he's wearing, I'm sure, is from Ghana. And he wears this everywhere he goes in the world. Everywhere he goes in the world, he wears Ghana. And so he's an ambassador for Ghana. So, Prof, we would like to add more of Ghana to you so that you showcase us more. Yes. Can wear it to the next one. Yeah. Thank you very much. So the picture, please. Thank you. Thank you, Professor Sen. A round of applause, please. Thank you. Then next is our very own latest doctor in town. I said I will not stop saying it. It's a very good achievement. We've agreed to keep celebrating to 2035. So everywhere we go, everywhere you will see us in the world, in Ghana, everywhere, we will keep mentioning it. And very soon, Sabina and Nima and everybody who is part of this project will start blowing our own horn. If you don't want to tell us, we will blow our own horn. So please, let's welcome Dr. Mercy Atieno. Also, thank you, Mercy. We appreciate you. We are grateful. We know the long nights that this has gone through. So I am told by these ladies that you could actually sew this, take it to church, to our outdoorings, obviously not to the nightclub. Okay, so this is for you. Thank you very much. Just come forward a little bit. Thank you very much. In one of our languages, in Akan language, we say "sepeni jariana inshasa." Okay, literally meaning when the elderly takes his or her bath, then automatically the water is finished. So, without much ado, I call on our own head and boss, Professor Charles Newton, who is the global lead for EPINA and the head of all these projects. Prof, we appreciate you and your efforts for us. We would like to spoil you in Ghana. Yeah. Okay. I just heard that he was installed as Nkoswahini in Dodua recently, yeah. So, oops. And the hand goes slots in. Thank you very much. So it's picture time.
You all come to the last room.
Okay. Thank you very much, Charles. Bless you. Most grateful. Okay. And to our partners, we are very grateful to you, the Ministry of Health. You've been heavily represented here, and we thank you for your presence. Without you, we wouldn't have a successful technical meeting, and so we are grateful. It is our prayer that whatever we discussed here, all our outcomes would find its way in your deliberations at your BMCs, at your committees, ICCs, whichever platform that you have that you take decisions for the health of the Ghanaian. We pray that these information gets in there so there is change. It is very important for us that all the things we've talked about here finds its way in policy so the ordinary Ghanaian can benefit from all of these. So we thank you very much for coming. To Ghana Health Service, we cannot say much. You've been with us from the beginning. All your facilities have given us the help till now. Your medical superintendents, the doctors that are assigned to us, the nurses, they've been wonderful. They've been wonderful throughout the journey till now. So we thank you very much. And to our technical partner, the WHO, we thank you also very much for being part of this project. You've shown that truly you support the EPINA team and the EPINA project worldwide, not only in Ghana. So we are most grateful. To all our CBOs, the community-based organizations, the Ghana Neurology Association, Ghana Epilepsy Association, all of you, we thank you so much for your time and your presence with us. And to our persons living with epilepsy and their caregivers, we thank you for coming. The struggle is real, we understand, and that is why we are in with you. All you need to know is that you have a partner to support you throughout this journey. That's the most important thing that you need to know. And our doors are open. You can call us anytime, and we would respond appropriately. So to everybody else who is here, to our Dodua, Pram, the Health Service, the University of Ghana team, everybody, we thank you for your time. Before I bring this to a close, I would like to hear a few closing words from our partners, particularly maybe you take Professor Charles to say a few words, and then we are able to continue from there.
Great. Thank you very much, Daniel, and thank you very much for everybody who stayed on and lasted throughout the entire meeting for the last 2 days. So as I mentioned in my opening address, we've been working here since 2008 and with our partners, with Albert and Patrick. And it's been it's an absolute pleasure to work and also with in Ghana, but also to see how much has been developed in Ghana in terms of raising the awareness about epilepsy and providing some crucial data that the Ministry of Health can utilize in order to try and estimate the burden and the resources and the services that are needed for epilepsy in order to support the people living with epilepsy, but also their families and in the wider community. And I think that we've got some takeaway points that we're going to work on in the next couple of years. And under the leadership of Patrick and Albert, we'll be in a very good position in order to really highlight epilepsy and other neurological diseases, and also the psychiatric comorbidity associated with epilepsy, in order to try and improve the welfare of people with epilepsy and their families. So I think there's a great congratulations to you, Daniel, Patrick, to you, and Emmanuel, Sabina, for all helping to organize this, and everybody. It's been very successful, and thank you very much. And what we do look forward to is the action points that will be taken forward and see the development that will occur in the next couple of years. So thank you very much. Okay.
Thank you very much, Professor Newton. We are very hopeful for more of these collaborations. So we will next take our closing remarks also from our Ghana lead, Professor Patrick Eje. Just give us a closing remarks and then we are done for today. So please, let's welcome Professor Patrick Eje.
Good afternoon. Thank you all for this wonderful program. I do appreciate or see that many of you here had a wonderful time. You have come to appreciate what the challenges of epilepsy is in this country, and then all the information from the workshops that we've had, all the 4 or 5 of them, that we are going to go ahead, particularly from the ministry, to help implement all the challenges that can improve the care of epilepsy for our dear patients in the country Ghana. Access to medicines, the availability of drugs, education and training. And these are all very important aspects of the things that we picked up in our study. And like Charles said, we'll continue to have the collaborations. This is not the end of it. It's going to even foster into better collaborations, which will help the patients living with epilepsy within the country. So on behalf of the EPINA Ghana, our great University of Ghana, and all the collaborators from University of Oxford, UCL, Nairobi, Kemri, Kilifi, all the collaborators, we bring this wonderful workshop to an end. And we do hope that those of us traveling outside would have a safe travels on their journey and safe arrivals. And those of us that are still around, we are having a wonderful training session for all persons who manage epilepsy tomorrow, and we in the same venue, and all those that are invited know themselves, and we expect you all tomorrow to be ready for that wonderful training session. It's still part of the plan to improve care for patients living with epilepsy. Thank you all once again, and thank you all for coming.
Thank you so much, Prof. So, ladies and gentlemen, I'm not going to say much. All to say is thank you, and until we see you again very soon, we would like to say thank you and God bless you. Have a good weekend, and we'll see you another time. Thank you all. Just a quick announcement, please, to the partners. Ensure that you sign before you leave, and ensure you see a gentleman called Vincent. He's just out there. Before you leave, please. To all partners, ensure you see Vincent before you leave. Thank you. And those who took the notes, please, you know what to do. You need to send them to me. You need to email them to me, please. Both groups, kindly email your outcomes and final ones to me. Thank you very much. Thank you. My photographer has told me that people are not using the cardboard for the pictures. So please, you need to hold it and take pictures. There is a frame that we take the pictures in. Kindly take your picture so that we can have a good album for this workshop. Thank you.